Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle.
Hello, guys. A very good evening to all of you, and welcome to DRDCA 2020 scientific session. I am Dr. Pallavi Mahajan, your host, dost for the scientific sessions. I have been the host, and I've loved the journey. So, I myself am an endodontist, a writer, and a spoken word performer, and most importantly, your host for scientific sessions in DRDCA 2020. So, guys, this has been a heck of a journey. We started on 1st of November, so many sessions, and now two sessions are left. One is today and another one will be on Saturday. So, and then Sunday we have awards night, right? And we'll be done with Dental Reach conference, and I'm going to miss it so much. November had been fun, and to be honest, I can be there in December also doing the same thing that I've been doing. So that was DRDCA has been very special to me, and you guys have been very special because you have always been there to listen and to ask questions. Uh, Thanks to Dr. Nupur, Dr. Roxon, the whole team of DRDCA, and to the amazing speakers. So when we talk about live conferences or live performances, when the speaker speaks, there's an audience sitting over there in front, and listeners are nodding their head. You can see their expressions. And in the live, in this virtual conference, what happens is speaker is on this side of the screen, he or she cannot see anyone, so it gets tough. And but it's interesting, right? And I honestly, I from bottom of my heart, I want to thank all the speakers for doing this with us and being a part of DRDCA. So just one pointer in the beginning, that before starting today's session, and that is, if you have not yet registered yourself for DRDCA 2020, please do so. Just two sessions are left. Don't miss them. You can always go back and see the sessions. All of the sessions are there on YouTube, on FB, and DRDCA app. To register for DRDCA, what you need to do is download Eventi app, go to DRDCA, select it, you will get registered, attend one or two sessions and fill the feedback form, and you'll get certificate of participation and almost 40 CD points. And on that note, yes, Dr. Nupur is saying that we are planning more events soon. So yes, hopefully we'll see you soon. On that note, let me start today's session. Today is a special session because it's my favorite topic, endo. Obviously, I'm an endodontist, so I'm looking forward to it. And prostho. So endo prostho session, combined session, and I am sure that these numbers are going to rise. There'll be more people who will be joining us. The first speaker that we have today is Dr. Rohit Shetty, who's joining us from Bangalore. Dr. Rohit Shetty has done his master's in prostho and implantology. Presently, he is working as a professor and HOD in KLE Society's Institute of Dental Sciences, Bangalore. He maintains a private practice in Bangalore and focuses mainly on fixed prostho and complete dentures. He's an active member of Indian Prosthodontic Society and Bangalore Prosthodontic Forum. He's an active member Society of Dental Aesthetics since 2015. Diplomate, American Board of Aesthetic Dentistry, 2019. He is a joint secretary of International Association of General Dentistry, editorial board member of multiple peer-reviewed journals, managing editor of World Journal of Dentistry. He is an accredited smilist dentist, key opinion leader at Edelweiss and Ketten Bank. Dr. Rohit Shetty is going to speak about blending bioaesthetics and function. He is going to introduce us to prefabricated veneers, single unit post core systems, and much more. So I am actually looking forward to this session. And guys, just so that you know, the sessions, we have two sessions. One is by Dr. Rohit Shetty. Following him will be Dr. Nikhil Bahuguna. And we'll have combined question and answer session. But you guys, please keep posting your questions as you are hearing or as you're getting them in your mind, and we'll make a note of it, and we'll make sure all your questions are answered. So on that note, I'll welcome Dr. Rohit Shetty on your screen now. A very good evening, sir.
Good evening, and thank you for your kind words. Thank you so much.
Thank you, sir.
So, good evening to everyone who's tuned in for this session, and I consider it a real privilege to be a part of this DRDCA 2020, where they've had a huge galaxy of speakers who've been churning out one blockbuster session after another. So I really hope I too live up to the same expectations. So I'm also very thrilled to be speaking on a very topic which is very close to my heart, that is aesthetics. So can I share my screen?
We can see your screen, sir. Yes. You can share the presentations.
Yeah.
Yes, sir.
Yeah. So I'm extremely thrilled because not only am I a part of a galaxy of speakers through this digital conference, but also I get to speak on a topic which is very close to my heart, that is aesthetics. The mere pronunciation of the word aesthetics basically signifies beauty, and what better joy for us clinicians basically to provide our patients with that perfect smile. And here I'm just not talking about the patient's happiness, but ours as well. But often in our quest to obtain that optimal aesthetics, we do run into challenges, right? And so with my discussion today, I hope to untangle these challenges, but I would be doing that with a twist. I would be doing it the Edelweiss way. Metal ceramic restorations have been a part of clinical practice right from 1850, and even our zirconia restorations have been around from 1900s. So we've basically been providing our patients with basically an option which is close to 120 years old. Yes, lots has changed with regards to strength, mode of fabrication, translucency, but the overall picture has remained the same. We just haven't moved further on. I'm sure that everyone who's logged in today and who's passionate about their practice would always love to know the answer as to where is aesthetic and functional dentistry heading. So I'd like to ask everyone who's logged in as to why hasn't things changed? Obviously, the answer for this would be that either we are very satisfied with what we have, or we don't see any scope for improvement. Like the old saying goes that we never fix it unless it's broken, right? So very similarly, we don't look for newer innovations, newer concepts, which would help us in our clinical practice. But I'm sure all of us as passionate clinicians would love to move forward where we can provide our patients with minimal preparations, lesser chairside time, and better aesthetics. We just can't be grappling around with technology which was used when people were driven in horse-driven carriages. We now live in the 21st century, and patients are very, very conscious as to what we provide them. So we obviously have to give up our colonial practice, and we need to move ahead with time. We need to adapt our newer methods, change with time, and at the same time stick to the old principles, and that's the only way forward. As the famous quote goes, great hands need great minds. One such concept that comes to my mind is the Edelweiss concept. And trust me, friends, not very long back, maybe 3.5 years back, before I incorporated this innovative concept into my clinical practice, I was pretty skeptical about the fact as to how a composite-based restoration could provide us with better results. come on, we've all been taught in dental school that metal ceramic restorations is like Thor, the god of lightning, but him also we've seen eventually fall. So before I go any further in my presentation, one thing that I want to make very clear is that I'm not here to replace traditionally used techniques, but basically introduce all your young minds to an alternative technique that has worked wonderfully well for me and for a lot of clinicians worldwide. So I basically present to you the innovative concept from Edelweiss. So over the next 40 minutes, basically we would be all traveling a journey together where we understand what this progressive concept is all about, which guarantees us to be minimally invasive, clinically effective, and provide cost-effective options for all our patients. So what exactly is this Edelweiss concept? Is basically a direct veneer system. As you can see in the slide, it's the basic core is made up of composite and it is bonded onto minimally prepared teeth using composite. If I'm this brief with regards to my presentation regarding Edelweiss, I wouldn't be doing this concept any justice. So let me spend some more time in explaining as to how and what it actually is. So these veneers, these prefabricated veneers are available in different lengths and different widths. As we all know that one size doesn't fit all. So a detailed analysis of the anatomical variations was carried out and a universally acceptable size range was arrived at. So these prefabricated veneers from Edelweiss are available in different sizes. For the maxillary arch, in fact, it's available in 4 sizes ranging from an extra small, a medium, and a large. While for the mandibular anteriors, they come in 3 sizes ranging from a small, medium, and a large. Unlike other manufacturers, it's basically focused on the anterior teeth. Edelweiss also has veneers for the posterior teeth, known as the OVs, where the occlusal morphology has been carefully incorporated into each of them. These OVDs, they stand for occlusal vertical dimensions. They are again available in 3 different sizes, a small, a medium, and a large. So this is how the Edelweiss veneers would appear, both for the maxillary and the mandibular teeth, for the anteriors as well as the posteriors. So before we have any misconceptions with regards to these veneers, I want to make it very clear that these veneers are extremely thin, especially at the cervical aspect, just around 0.2 of a millimeter. So probably double the thickness of a strand of hair. On the facial aspect, they're around 0.6 of a millimeter. And at the thickest portion, that is at the incisal edge, they're around 1 to 1.3 of a millimeter. So you can kind of analyze that these veneers, they blend beautifully, they look natural, and they blend beautifully with the adjacent teeth and the periodontium, and they do not look artificial and bulky. Similarly, the OVDs, the occlusal vertical dimensions, as the posterior veneers, also in the marginal area are very thin, just around 0.1 to 0.2 of a millimeter, while in the occlusal area, they are around the thickness of around 0.3 to 0.6 of a millimeter. So this is the direct veneer system from Edelweiss for the maxillary and the mandibular arch, for the anteriors and the posteriors. And I request of you all to take a few seconds to appreciate the fact that how the anatomical contours have been carefully crafted into each of these veneers. They're just not blocks of composite. And at the same time, they've been maintained at minimal thickness. And these veneers and these OVDs can further be reduced in thickness, but obviously that needs to be done with utmost care. A lot of manufacturers have tried their hands at these prefabricated systems. So before you discard the Edelweiss concept as just one amongst them, have a look at its properties in comparison to the other systems. It scores over them handsomely with regards to strength as well as hardness. What I want you all to focus on is its high flexure modulus, which basically enables us to adapt these veneers on the convex surface of the teeth, where they tend to bend and flex over and adapt very beautifully over the convex surface of the teeth rather than breaking. So this higher flexure modulus contributes to the bending and flexing action of these veneers. As we all know that seeing is believing. So this is how the Edelweiss veneers would appear after a year in service in the oral cavity. You can appreciate that it has the same translucency, glossiness, and the lifelike appearance, while the other systems cannot replicate the same aesthetics after use in the oral cavity. So basically now all of you all would be wondering as to what is the secret sauce behind this magical material. Well, most of the advantages are due to the manufacturing procedure. So what follows is a behind-the-scene look as to how these veneers and these OVDs are fabricated.
With direct veneer and occlusion VD, Edelweiss Dentistry presents an outstanding system. With direct veneer and occlusion VD, Edelweiss Dentistry presents an outstanding system. The unique manufacturing process combines the best of two worlds, wafer-thin veneer and occlusion shells, together with an inorganic surface as hard as dental enamel. The basis consists of a highly filled homogeneous nanohybrid composite material. In a first step, this material is heated and injected into special molds. At over 300 degrees Celsius, the mass is now polymerized thermally as well as through light and tempered for half an hour. This results in a solid and yet flexible blank. Now follows the core of the treatment. A laser penetrates 80 microns into the blank. This sinters the glass particles and extracts the resin parts from the composite material. Finishing is performed in a second step. Finest glass particles are applied to a sintered surface and vitrified using a coating laser. The result is an inorganic high-gloss glass surface, fused with the sintered dynamic composite core. The biomechanical properties of natural tooth enamel have been optimally reconstructed, merged together with natural bioaesthetics. The difference is in its similarity with nature. The direct veneer and occlusion VD system by Edelweiss Dentistry.
So I was basically harping a lot about the right implementation of technology when I started off with my presentation. So now if someone asks us if anything has changed over the last 120 years, we can definitely answer in the affirmative. The laser vitrified process that you just with in the previous video is basically an innovative technique which involves adapting minute glass particles along with the inorganic composite with a coating laser. And this is responsible for the optimal bioaesthetics, the translucency and the lifelike appearance of these veneers. The composite core is both strong and flexible with a coating laser, and what we end up with is a smooth inorganic surface which has been devoid of any resins that has been extracted by the laser beam. The SEM photograph basically shows us three distinct layers: an upward distinct layer of a vitrified glass, which is responsible for the glossiness, the translucency, and the lifelike appearance of these veneers; a laser sintered body, which is completely homogeneous, devoid of resins, and this is responsible for the higher flexure modulus, which I mentioned earlier, enables the veneers to be well adapted onto the convex surfaces without breaking. As you can see, the other systems have a lot of structural inadequacies. So this is the final structural bond that we achieve between the veneer and the tooth surface. And what plays an integral role in this bond is the veneer bond, which is applied onto the intaglio surface of the veneer. Veneer bond is different from our universal bond. It's basically a clear bond which has a silane incorporated into it. So what we end up with is a veneer which provides us everything that we need, and in fact, it has an improvement in its physical properties once bonded onto the tooth surface. So let me walk you through some cases. Firstly, in the anterior region, when we're using these prefabricated veneers, majority of the teeth that we plan for placement of these prefabricated anterior veneers would require minimal or no preparation. This particular case, the tooth was discolored, so we needed to prepare to ensure that we got rid of the gross discoloration. Once the tooth is prepared, we condition the tooth, which basically involves etching it with phosphoric acid. We wash, dry, then we apply 2 coats of your universal bonding agent, lightly air dry, and cure it. Then, using the sizing guide, I had mentioned earlier that these prefabricated veneers are available in different sizes, and we also showed you the sizing guide, which is basically can be used to select the appropriate size. For the maxillary, we have sizes ranging from an extra small right up to a large. So when you are stuck between 2 sizes, say if you're stuck between a medium and a small size, always select the larger size, as it can be customized for the individual case. So after you select the size, you customize the veneer. It's also recommended that you always use a slow contra-angle micromotor for all the customization, so that you have better control over the customization and trimming of these prefabricated veneers. It's also strongly recommended that the cervical and the proximal aspect should be trimmed into a knife edge, so that when adapted over the tooth surface, it blends beautifully with the tooth surface at the interface. Once all the customization is done, the prefabricated veneer is cleaned with an alcohol swab. Then we use the veneer bond, which I had mentioned earlier. We apply 2 coats of the veneer bond onto the intaglo surface of your prefabricated veneer, lightly air dry, and cure it. We then select the shade of the composite from the adjacent teeth. Mind you that the entire shade of your restoration will be derived from the composite that is used to bond these veneers. The veneer shell is basically a translucent shell. It wouldn't contribute significantly to the shade outcome. So we need to select the shade of the composite, which is used for bonding based on the shade of the adjacent teeth. Even if we use a single shade of composite to bond the entire prefabricated veneer, the veneer will appear polychromatic. This is simply because the veneer varies in thickness from the cervical to the incisal aspect. But again, we can play with composites where we can use a darker shade at the cervical aspect, a lighter shade at the body and the incisal aspect. There are also a lot of effects available, such as the effect blue, which mimics translucency. We have the effect ice, which is again applied onto the intaglo surface, and it can mimic hypoplastic spots on your veneers. So there are a lot of effects that can be used. Once we place the composite onto the and evenly distributed onto the intaglo surface of the veneer, we position it over the prepared tooth. Always remember to pass a mylar strip through proximally, which ensures that the excess composite can be used to merge the interface between the prefabricated veneer and the prepared tooth. Once we've got the position right, we tack cure the prefabricated veneers for around 3 seconds. Then it facilitates easy removal of the excess cement from the proximal region as well as the cervical region. And once that is done, we can do the final curing. Once it is bonded in place, we can even use your rotary instrument. Your yellow band diamonds can be used to round off point angles, carry out some external characterization, get rid of any stubborn remnants of the composite on the cervical aspect, the works basically. And then we can polish these prefabricated veneers using your Softlex discs, your diamond impregnated cups, and obtain a luster very similar to what the veneer possessed when it was removed from the packaging. So this is the final veneer in place, and you can see how well it has blended beautifully with the adjacent teeth as well as the surrounding periodontium. And that's why I'm a big fan of the aesthetics of this system. Another anterior case. So if I have to check as to what is wrong in this particular clinical scenario, the answer is everything. Everything is wrong. There are spaces, there are discolored teeth, there are badly made or fractured metal ceramic restorations. So this also can be rehabilitated using this concept, where initially we prepare the teeth minimally. We also ensure we get rid of all the unsupported ceramic. We can then choose to etch the tooth surface with phosphoric acid and cleanse the ceramic surface with phosphoric acid. Again, wherever there is ceramic, you condition the ceramic by using your hydrofluoric acid, where we etch it with hydrofluoric acid, apply a silane coupling agent. Wherever the metal is exposed, you can also use a metal primer to enhance the adhesion of the composite onto the metal surface. Following which, we can use another effect which is available in the kit, known as the opaque white, which is used to mask the underlying dark substructure. It's applied basically on the existing restorations to mask the underlying this dark color of the metal. Following which, the veneers are selected. The veneers are customized You apply the veneer bond, cure it, place composite, and then they're bonded onto the uh, tooth surface as well as the existing restoration. A word of caution is whenever a patient presents with spacing, always remember that composite should be built up onto the palatal aspect, where we etch and bond and build up composite on the palatal aspect to bridge the space. This basically provides for support of your prefabricated veneer. If when we are placing these prefabricated veneers in clinical scenarios which present with spaces and there's no support, obviously the veneer is susceptible to fracture, very similar to our ceramic veneers. So whenever there is a space, bridge the gap from the palatal aspect using composite. We go about bonding these veneers on the teeth as well as the restorative surface. You can see as to how well these veneers blend on the incisal edge as well. And this is your final result. And I'm sure most of us who are logged in now would are pretty confident about the capabilities of this system, where we can provide our patients with a good aesthetic makeover, however complicated the clinical scenario is, using minimal preparation and time. So moving on to another material which I mentioned earlier, that is your OVDs, that is the occlusal vertical dimension, which I personally consider a big boon for our post-endodontic treated teeth. They can also be used in such clinical scenarios where the patient presents with a discolored existing restoration, so you can rehabilitate the occlusal morphology beautifully, both functionally and aesthetically, using these OVDs. They work very well even in clinical scenarios where not only is the existing restoration aesthetically unacceptable, but also fractured. As a prosthodontist, it really appeals to me when I get to use these OVDs in such clinical scenarios where the patient presents with generalized attrition, where we can rehabilitate the entire occlusion using a minimally invasive technique, and I truly mean a minimally invasive technique. So let me walk you through a posterior case. Here again, the patient presented with a fractured metal ceramic restoration. So for starters, we get rid of the ceramic on the occlusal surface, as well as the unsupported ceramic from the axial surface. Again, the OVDs are available in different sizes, for which we have a sizing guide. We select the appropriate size. We try it on. Whatever discrepancy exists between the marginal ridge of the OVD as well as the marginal ridge of the adjacent teeth, we trim the cervical aspect of the OVD to ensure that there is a good harmony between the marginal ridge of the natural teeth and the OVD. And then we prepare the foundation, that is in this case, the existing fractured metal ceramic restoration, where the ceramic surface can be etched using hydrofluoric acid, silanized, while the metal surface, you can sandblast it and roughen it. You can also choose to use a metal primer to enhance the adhesion of the metal onto the composite. After the bonding agent has been applied and cured, we can also choose, and we should obviously in this case, mask by using the effect, that is the opaque white, which is a flowable composite, which is applied onto the metal substructure and cured. The selected OVD, which has been customized, you have again applied the veneer bond onto the intaglo surface. It is cured, after which you dispense the composite. And here again, the shade of the composite will determine the final shade of your final restoration. The composite is dispensed onto the intaglo surface, evenly spread, and then you place it over the occlusal surface, where you ask the patient to lightly close onto the OVD. What happens? The OVD gets relined according to the occlusal surface of the existing restoration. In this case, the excess composite can be made to adapt onto the axial surface and build up the axial contours of the tooth in question. After we've done all this, we tack cure the restoration in place, after which it facilitates removal of the excess cement from the proximal region as well as the cervical aspect, and then we do the final curing. We then check for the restoration if it has any occlusal discrepancies. We simulate protrusive and lateral movements, eliminate all the interferences, and then again ensure that basically the restoration is sans any interferences, and then we polish the restoration using your Softlex discs, your diamond impregnated cups, and again we have a restoration which is both meeting the requirements functionally and aesthetically. It really looks simple, doesn't it? It actually is. And what is really fascinating is that when a patient, say, for example, walks into our dental office seeking a restoration for a tooth which has been endodontically treated, In that same appointment, we can provide the patient with a restoration in probably 20-25 minutes, and the patient leaves the dental office with the restoration in place on the same day. And to be honest, this in the true sense is innovation. These OVDs can also be used in the posterior region to replace single missing teeth in harmony with your fibers. So, say this clinical scenario where the patient presented with a missing second premolar, you prepare minimally on the mesial aspect of the molar, where you prepare a mesial box, and on the distal aspect of the premolar, again a mesial box is made. You etch and bond the fiber into place. Using a sizing guide, we select the mesiodistal dimension of the edentulous space, and we select the appropriate OVD for the case. After which, we apply the veneer bond on the intaglo surface, cure it, place a lot of composite onto the intaglo surface, and place it over the fiber. Always remember to pass a mylar strip on the undersurface of the composite so that we can shape the undersurface to obtain the pontic design that we desire, which in this scenario is a modified ridge lap. And then we cure it in place, after which we can use your rotary instrument to deepen the embrasures and to reshape and obtain the ideal pontic design, and then again polish our restorations. If these OVDs were used only for post-endodontic treated teeth as well as only for salvaging fractured metal ceramic restorations, then its job only would be half done. These OVDs can also be used for full mouth rehabilitation cases using both the direct as well as the indirect technique. In the direct technique, we basically put the patient through a splint therapy where we deprogram the mandible, get the right position of the mandible with regards to the maxilla. We also create the desirable interocclusal space that is required for the functionality and the aesthetic requirements of our OVDs, after which we bond these OVDs onto the occlusal surface of the teeth against the antagonist, thereby developing the occlusion as well as restoring and increasing the vertical dimension. But to be honest, using OVDs for a full mouth rehabilitation using the direct technique is easier said than done. So I always recommend that whenever we're doing a full mouth rehabilitation using these OVDs, it's always desirable to do it using the indirect technique. So in the indirect technique, we basically again put the patient through a splint therapy where the mandible is deprogrammed. You obtain the ideal position of the mandible with regards to the maxilla. We create the interocclusal space. We then transfer the patient's cast onto the articulator where using a Facebook record, and then we make intraocclusal records as well, which again mimics the intraocclusal space that we desire for the functional and aesthetic requirements of our restorations. So what is desirable is that when we are making these intraocclusal records, always ensure that these intraocclusal records are unilateral. So why I recommend that we place these intraocclusal records unilaterally is that when we place it on the right side of the articulator, what happens? The left side gets de-articulated, means it gets disoccluded. So then on the patient's cast, what do? We select the OVDs, we customize them, we apply the veneer bond, cure, place composite, and then we place them on the occlusal surface on the patient's diagnostic cast. So basically it gets realigned according to the occlusal surface of the patient's teeth. And then we stabilize it with sticky wax. So we do this procedure for all the posteriors, develop the occlusion on the articulator. Once we've done it on the left side, obviously the right side gets disoccluded. We carry out the same procedure for the right side, develop the occlusion. And once we've done that, we can also choose to simulate protrusive and lateral movements on the articulator, eliminate all the interferences, and finally polish our restorations. And on the clinical appointment, bond these OVDs onto the exact same position intraorally, and again carry out any minor adjustments that requires to be carried out intraorally as well, and polish our restorations in place. Again, for some of you all who would wonder, can you please open the curtain? So for some of you all who would wonder as to how these composite-based restorations would withstand the rigors that we anticipate in the posterior region, well, you can have a look at its properties, and you can see from the chart that it boasts of sufficient strength and hardness that is desirable of a posterior restoration. And again, its fatigue resistance boasts of similar evidence. So we've treated a variety of cases using these prefabricated veneers, the occlusal VDs. But here I want to go a step further and I want to do a full Monty where I want to also rehabilitate cases, as you see on the slide, which basically presents with debilitated dentition, broken down teeth. So here, not only, obviously, we just can't build them up with composite, can we? So this is where the newly developed single unit post-course system from Edelweiss comes into play, where it provides us with the advantage of simplicity and convenience, and at the same time follows the Edelweiss principle of function and aesthetics. So what's the first thing that comes to your mind when you all see the post-course system from Edelweiss? It's basically of a single unit. So what's the next question in mind? Why do we need it to be of a single unit? Well, when we talk about the conventional post-course, what do we see? We have many interfaces. More the interfaces, more the chances of the failures across these interfaces. So again, like in a regular conventional post and core system, there are a lot of chances of the stresses developing in the cement that is used to cement our post and core, and that could lead to a failure. Also, the polymer matrix of the composite makes it complicated for it to bond onto the post material, again leading to a failure at that interface. So there are several interfaces where commonly we see failures. So how do we solve this issue? We again solve it the Edelweiss way by making the post-course system of a single unit, by eliminating the main interface across where we see the maximum failures. Again, this post-course system doesn't follow the philosophy of one size fits all. They come in different sizes. Again, they are not the same post-course system is used in the anterior region and the same in the posterior region. They've been customized. For the maxillary anteriors, we have a separate set for the mandibular anteriors, a separate set for the maxillary premolars, differently for the mandibular premolars, and lastly, a different set for the molars as well. So what's the first question that comes to our mind whenever we are faced in our clinical situation, in a clinical scenario with a broken down tooth? Our first question that we ask ourselves is the tooth restorable? So if a tooth presents with a favorable ferrule where it presents with a length of 1.5 to 2 millimeters and a width of 1 to 1.5 millimeters, then we go ahead with the endodontic treatment. And if any of these parameters are compromised, we need to think alternatively, where we need to either extrude the tooth or do a crown lengthening to obtain the desirable ferrule. So what's the next most critical question that we need to address? How much of tooth structure remains to retain the core material? If there are 2 or more walls, we basically build it up with composite. Anything less than that, we obviously need to place a post so that it can retain the core material. So if these were to represent clinical scenarios, situation 3, 4, and 5 would warrant placement of a post to retain the core material. I have given a lot of emphasis on evolution, right? But to be fair to the post-core system, they've been constantly evolving. But for Edelweiss to come up with a new system altogether basically shows that there's always scope for improvement. Anyone who's from my generation would have definitely worked with the metal posts. The metal posts, but again, one look at it and you know that it's an aesthetic disaster. It again has a very high modulus of elasticity, and it's also very prone to corrosion. So a lot of us moved to the carbon fiber post, which was easy to cut, easy to remove, and very importantly had a modulus of elasticity similar to that of dentine. But again, its limited radio opacity and its unsatisfactory aesthetics didn't work in its favor. A solution to a lot of our problems, what do we turn to? We turn to zirconia. Here again, it had good biocompatibility, great aesthetics, and radio opacity, but its modulus of elasticity was even twofold that of metal, and retrievability was a big issue with these zirconia posts. Then we had the glass fiber posts, which basically ticked most of the boxes. It was easy to cut, easy to remove, and very importantly had a modulus of elasticity similar to that of dentine. But again, limited radio opacity, and more importantly, it required a core buildup, which was a major interface where failure occurred. So how do we address this issue? Like I mentioned earlier, with a single unit post-core system. These single unit post-core systems from Edelweiss basically have a transparent post and an opaque core. like I mentioned earlier, they've been customized for different segments of the oral cavity for different teeth. You'll soon realize that they're very easy to use, thereby reducing the chairside time. What really appeals to me is that when I prepare the core, it prepares just like dentine because it basically has a modulus of elasticity similar to dentine. It boasts of great adhesion to the root canal walls and great visibility on the radiograph. So basically, the Edelweiss post-core system is like the Superman of the post-core systems. So this is what we can seamlessly achieve from the Edelweiss post-core system, where it provides for maximum protection of the root, maximum protection of the crown margin cement seal, great aesthetics, great visibility on the radiograph, and retrievability. The most important factor which really tilted my usage towards the single unit post-core system is that it provides for a monoblock effect, where the entire unit functions as a single system. So there are no chances of stresses and cracks propagating through the system, and hence chances of failure and debonding are minimal. The laser vitrified process that we are familiar with now, it comes into play here as well, which basically ensure that this post and core system has a modulus of elasticity similar to dentine, and in fact, it has a bond even stronger than that to dentine. So this video will basically introduce us to the protocol that we need to meticulously follow while using this post-core system. So you can basically kind of visualize as to how, when a patient presents with a broken down tooth, we can basically try and get the clinical scenario as close to normal as possible. So with as far as this post-core system, I would go a step further and say that this is just not innovation, it's basically a piece of art. And I'm sure all of you all would have faced a clinical scenario such as this, where the patient would have presented with a broken down tooth, probably due to weeks or months of neglect, post-endodontic treatment, and then they plead with us to somehow salvage this particular tooth. So with this newer inventory, we can definitely provide better longevity for such teeth. So for starters, we need to prepare the post space, which has to be done with the drill kit provided with the post-core system. The drill kit comes in two diameters, which basically corresponds to the length and diameter of the posts available to us. So you create the post space is created, after which we try on the prefabricated post-core system. We then prepare the canal as well as the residual tooth structure, where we etch it with phosphoric acid, wash it, clean it, blow it dry, and make sure that you use a lot of paper points to ensure that there are no remnants of the etchant within the canal. After which we apply the bonding agent, 2 coats, lightly air dry and cure it. The veneer bond is then applied onto the post, lightly air dry and cure it as well. Then we dispense the cement from the apex upwards. We then place the selected prefabricated post-core into the canal. All the excess material is made to merge at the interface between the core as well as the tooth material, tooth structure. Any deficiency with regards to, if there's a slight gap between the core as well as the residual tooth structure, it can be filled up with your flowable composite, and then it's bonded in place. After which we can prepare the tooth surface to receive, say, a metal ceramic restoration or a zirconia restoration. And this is where the beauty lies for me as a prosthodontist, because when I prepare the core material, it basically prepares very similar to tooth structure. Unlike other materials, when I'm preparing, it's like a hot knife through butter. This prepares exactly like dentine, and I'm sure you all will all agree with me when I say that the final result is more conducive to receive a final restoration than how the patient had initially presented to us. So basically, Edelweiss has a very simple motto: beautiful innovations you can trust. And I've been harping about this concept for the last 40 minutes, and many of you all would be wondering whether I truly believe in this concept, because mere words has no value in today's world. I believe in this concept to an extent that my very first full mouth rehabilitation case was my very own sister. And this was not my way of getting back to her or anything. It was basically because I truly believed in the potential of the system. My sister, who's a practicing pediatrician, had basically her rotten set of teeth where she had missing teeth, generalized atresion, abstractions, discolored teeth, ragged incisal edges, basically the works. So we first initially put her through splint therapy, where we deprogrammed her mandible. We also created the intraocclusal space that was desirable for the functional and aesthetic requirements of our final restorations. We did a faceboard transfer, transferred her cast onto a semi-adjustable articulator, and using the indirect technique, which I had explained earlier, we relined the OVDs on her diagnostic casts. We developed the occlusion at the restored vertical dimension. We simulated protrusive and lateral movements, eliminated all the interferences, polished our restorations, and on the first clinical appointment, bonded the OVDs on both the maxillary posteriors as well as the mandibular posteriors, developed her occlusion, restored her vertical dimension. We also bonded the prefabricated anterior veneers for the maxillary teeth. On the second clinical appointment, we bonded the prefabricated veneers for the mandibular anteriors, and we were able to transform her smile from one which was a flat incisal edge with ragged incisal edges, discolored teeth, which was basically unattractive, to one which was very attractive. It was convex, following the vermilion border of the lower lip, blending beautifully with the periodontium. And I'm sure all of you all agree that we are just not smile architects. We basically provide our patients with a whole new personality. And that's exactly true with my sister as well, where this is a picture of my new sister, where she, along with her new smile, got a new hairdo. Now she has a huge collection of flamboyant lipsticks, and she's extremely active on the social media as well with a newfound smile. So I've been talking about this innovative concept and introducing all of you all to it over the last 40 minutes. And I really hope the last 40 minutes have been really enthralling for all of you all, as it has been for me. My aim here was basically to introduce you all to an innovative alternative concept which has been tried and tested. All the treatment modalities that you just saw can be tried and implemented into your clinical practice. And I personally feel it's changing the course of modern dentistry as I speak. So as I sign off with my discussion, I'd leave you with this video, which is basically a testimonial for the people who are working relentlessly behind the scene at Edelweiss to make dentistry simpler, innovative, and exciting as it should be. This video is from the recently concluded Indian customer workshop, which was held at Walford, Austria, where all the innovations happen. Thank you, one and all, for your patient hearing, and a very, very big thank you to the organizing team of DRDCA for providing me this wonderful platform where I could share my experiences regarding this innovative concept. And a big congratulations to all of you all as well for putting up a great show all through this month with a great galaxy of speakers as well as wonderful sessions. Congratulations to all of you all. And now we can stay tuned for our for Dr. Nikhil Bahuguna, because very importantly, he would be also telling us as to how we can prepare the foundation, as well as he would be focusing on rehabilitating extreme cases and preparing the foundation so that we can provide such optimal restorations. Thank you, one and all.
Thank you so much, sir. Indeed, great hands need great minds. And thank you for introducing all of us to Edelweiss concept. Thank you for introducing us to your new sister. I mean, we all know that it's so difficult, to work on your family members.
Exactly.
So we don't have any doubt regarding your dedication to this system, because thank you so much, because being an endo also, this conference as it is has told me I have so much to learn, and this session of yours was like a stamp on it. So I enjoyed it thoroughly. Thank you so much for sharing all those cases also. Since how long have you been practicing this system, sir?
Close to 3.5 years.
Okay. So I guess we'll wait for the question and answer session, sir. Please be here, and we'll get back to you post Dr. Nikhil's session.
Yeah,
okay. Thank you, sir. Thank you. So that was Dr. Rohit Shetty, and as I said, aankhein khul gayi bahut. So many things, and we are not aware of all those things. So thank you to DRDCA, and thank you to Dr. Rohit for sharing these things with us, for sharing the whole Edelweiss concept. They say it was like, when you see these cases, it's actually, as Dr. Rohit rightly said, it's not just dentistry, it's art, right? It's actually art, piece of art, which has taken shape over there. So carrying forward this art of the curve of art and the curve of learning, we have another amazing speaker with us. Just like Dr. Rohit, a very renowned speaker, a very renowned clinician, Dr. Nikhil Bahuguna, who's joining us from Delhi, from Noida. Dr. Nikhil has done his master's in conservative dentistry and endo. He's a diplomat, American Board of Aesthetic Dentistry, certified mellifier, Edelweiss and Lightspeed instructor, secretary and board of director, IAACD. He's a former professor and head of department, Kalka Dental College, UP. He's key opinion leader in Dentsply, Edelweiss, Dentapreg, Pulpdent. He runs his own private practice in Noida. Dr. Nikhil Bahuguna is going to speak about, as Dr. Rohit already mentioned, redefining the art of resto-habilitation. So it's art and art of restoring tooth. I guess conservative dentistry, conservation of tooth structure that we're going to talk about. And I'll let Dr. Nikhil take on the stage now and speak about it. A very good evening, sir. Very good evening.
Thank you very much, Dr. Pallavi, for that introduction. Let me just confirm whether you can see my screen or not.
Yes, we can see your screen.
So what better way to start by such an excellent session, which has been concluded by Dr. Rohit Shetty. Really, it's heartwarming to see the kind of work that he's been doing with Edelweiss concept. And the journey started together, and it's a great fellowship that we've had in the last 3.5, 4 years. Well, with continuing what Dr. Shetty left you with, let me first greet you all to this session of DRDCA 2020. It's just a small tradition I always follow, seek the blessings of the Lord Almighty before I start everything in my life. Well, formally, welcome to the session. You've already heard a part of restoration. Now, let me take you ahead from restoration to resto-habilitation, which I have very happily called it the art of habilitating teeth, which a lot of us would probably not have restored or may have given crowns to or may have extracted and placed some artificial substitute. But before I start, I never knew that Dr. Pallavi is going to introduce me so sweetly. So I'd already put in a few slides to introduce myself. So that's me, Dr. Nikhil Bahuguna. Currently, I'm the secretary of the Indian Academy of the Aesthetic and Cosmetic Dentistry. These are a few accreditations and accolades that I hold. And what you see on the screen is largely due to fellowship, due to learning, due to traveling with fellow colleagues, friends, and trying to gain as much knowledge and share as much knowledge as possible. What you see, I do share some commercial interest with a lot of companies that you will see on top. But always remember, the cases that are going to be discussed today are not those promotional cases or the ones that we have documented only to showcase. These are all fees for paid cases that have been done in our daily dental practice to show you the kind of faith we have in the systems or the materials or the concepts that we use. Well, that's my practice in Noida. It's called Demystifying Smiles. So just to give you a small tour of where I work. It's a very small little practice that I maintained in Noida for the last, almost the same name has stuck to me since 2004. And we believe in a very simple philosophy. I mean, you will see, it's a practice which is dedicated to restorative dentistry and endodontics. And all the work that you will see me showcasing has been done in these rooms only. So these four walls are a witness to my journey from a graduate to a postgraduate and finally to sitting here and talking to you at the DRDCA 2020. Well, as everyone says, the practice could be a multi-specialty practice, but I am not a multi-specialty dentist. I stick to my hardcore specialty, which is restorative dentistry and endodontics. And that's exactly what you see these little trophies and these little certificates are a witness of. They have helped me grow in my practice to a large extent and given me the confidence to do what I do. Well, that's my beautiful family, the picture of which I always keep up on my head because I need their blessings always. I also maintain an educational endeavor in Delhi by the name of EduArt Delhi, where we conduct a lot of restorative programs, and dedicatedly in Noida at my center, where we do a lot of basic training for root canals and restorative dentistry. You could visit us on Facebook on these pages, EduArt Delhi or Demystifying Smiles, to see the kind of work we do. Usually people thank at the end of their presentations, but I truly believe that I need to thank everyone at the beginning because you're the guys who are sparing your time and sitting with us right now digitally. The world has become a very small place now. You don't have to travel. You don't have to spend money booking tickets and booking schedules. Just on a click of a button, beautiful organizations like DRDCA make it possible for you and me to sit together and discuss our work and our practice. So thank you to the people who are sitting and watching me here right now. And the biggest thanks I would like to give is to the team of DRDCA 2020, Dr. Roxon, Dr. Nupur, Dr. Pallavi, Dr. Manu, who contacted me. Thank you very much for having me here today. And this group of people, I always have to acknowledge my wife and my son, because they've been the strongest support that I've always had when I've been traveling and doing dentistry with my total heart, and very little time could I spare to spend time with them. Thankfully now, in a lockdown, I'm reliving the 15 years that I have lost while I was traveling and working. So the topic that I'm here sharing today is redefining the art of resto-habilitation. Now, why did I choose the word resto-habilitation? It doesn't exist in a dictionary. We all see restorations being done, and we all see a boundary or a limitation after which we decide, okay, let's extract. And being a conservative dentist, being a restorative dentist, as I would more aptly call myself, I always thought, what if I can save this tooth? Or even if I can prolong the life of this tooth, or maybe heal the bone for some more time, we can have a better prognosis. The idea was not to give a substitute. The idea was to retain natural dentition. We started with the simple class 1s and class 2s, and then came those destructed teeth with posts and cores and OVDs and big contour restorations, fibers. We realized that we could work without extracting to a lot of extent. Well, this is just a funny disclaimer I always like to share, that the views that I'm going to express are based on science, my personal experiences of similar-minded people all over the world. But yes, feel free to disagree. The attempt is not to convince anyone, but to show what is logically possible. So take this with a pinch of salt and let's start. Let's discuss nature. We all, as dentists, and Dr. Rohit beautifully said, we are more than dentists, we are artists. But our art is not something that is on the canvas. Our canvas is the tooth. And we need to do our drawings, our sculptures, our designing such that whenever our art is put to some test, it works. Now let's see how tooth was fabricated. Now there's a simple picture of an anterior tooth where you have some dentine, some pulp, and a lot of enamel. Let's go through the
The bud
development.
thus turns into a dental cap. This cap is formed around the dental papilla. It is surrounded and protected by the dental follicle. The germ of each deciduous tooth is thus formed with a certain time lag. After this, we reach the bell stage. The tooth germ increases in volume and expands while creating the future enamel-dentin junction. Finally, the coronal dentin and enamel of the tooth are progressively formed along the cusp slopes.
So friends, you just saw this little revision from your histology classes, how the tooth is formed. And it's very clearly mentioned that first one layer is put down, then the second layer grows on top of it, which just goes to say tooth was never a monolithic structure. It was a bilayered structure. It was a structure laid down with cushion inside and hard enamel outside. But somewhere down the line, doing a promising unbreakable restorations, we forgot that hard does not mean strong. The strength lies in the resilience. Well, I found this funny picture somewhere on the internet, so I thought I'll just share it here. Both these gentlemen, the big fat guy and the small kid, wanted a ride. But just look at the opposites happening. The small boy got the Harley and the big man got the cycle. Well, both of them are doing good, but they cannot sustain the load of what is going to come on top of them, either with balance or with stability. That gets me to a very small discussion, fillings versus restorations. Because in generic terms, we always say, I am here for a filling, or let's do a filling for your tooth. What is a filling? So I could find no better example than a road, because we all know how roads are filled in India. We have a road which is cracked and we fill it with something which doesn't match the inherent nature of that material, the inherent composition of that material. And the cracks develop and they become potholes and potholes to craters. But when we say restoration, we have to mimic, we have to imbibe, we have to create those defects and repair them or recreate them with similar sounding structures. And that's what a restoration is all about. But a friend shared this picture with me, and this was the hardest hitting nail on the head when we realized that how are we restoring nature? Our entire focus, the hunt, the race for giving non-breakable restorations has led us to lie to our population that your fillings or your restorations or your crowns are not going to break. We are scared of telling our patients that when God made teeth could deteriorate, man-made teeth should follow physiological attrition, When there is extra load, they should crack, they should break so that the load does not reach the periodontium or the TMJ. Gone are the days when we followed G.V. Black's philosophy. I'm not questioning his caliber. What he taught us is unimaginable. It's very, very pristine for us. But we now have to move ahead with time. We started when we had big, huge cars. Now we have different advanced cars. We started with the big, bulky Nokia. Today we have small iPhones. We have air travel right now. We have the best facilities possible. We cannot stick on with what was available 2 decades or 2 centuries back. We need to move with time. This is the biggest farce I found in the fraternity discussing restorations. That let me, for the happiness of the patient, promise an unbreakable restoration, without understanding that teeth may still break. If everyone is thinking the same thing, trust me, no one is thinking. And we need to think so that we can make the right changes in life. We must have all seen this test, the hammer test. Without realizing, first of all, we don't hammer our teeth. And if at all, the force in our mouth is such that we are hammering the tooth, I would rather have the tooth break than the tooth not break and the forces go to my joint. Well, this quote was given by a great philosopher, Osho. It was not in a dental context, to be sure, but the context can be put to dentistry for very, very right reasons. It read that what is natural breaks or fades away, but what does not break or fade away breaks you. And here the you is not the tooth, it is the temporomandibular joint, which leads to a full disarray in the entire stomatognathic system. We promise a tooth which cannot break. The patient still would apply more loads. These highly strong, unbreakable restorations, 1000 megapascals, 1200 megapascals, they do not match the same load-bearing capacity of the tooth. The forces get disbalanced. We have an imbalance of the joint. The teeth start grinding. We call it bruxism. And one wrong filling leads to a full cascade, which starts from the tooth, goes to the periodontium, then the muscles, and finally the joint. And thanks to such beautiful technology, we have a whole new branch of medical health science, which is called the neuromuscular dentistry, the temporomandibular dentistry. We are now talking about splints. We're talking about muscle repositioners. We're talking about smilist concept. And little do we realize, one little restoration would have saved the entire problem from becoming so big and so massive. Well, what does a little poor tooth want? It's made up of dentine inside, enamel outside. So do we want 1200 megapascals, thousands of megapascals? No. The compressive strength of natural enamel, when supported by nice viscoelastic dentine, is 384. And the flexural modulus of that viscoelastic dentine, when it is layered by a hard enamel, is 18 GPa. So if somehow we can replicate these values, these structures, or if these properties can be mimicked, we may end up not cutting too many teeth and losing too many structures. So I always try to work with what biology gave us, and we have this beautiful tribiologic concept, which says restore using biomimetic concept, regenerate using the bioactive concept, and rehabilitate using the bioaesthetic concept. But I prefer for all these three things raisins. And trust me, raisins is not the past. Raisins are the future because they're conservative. They're equally aesthetic, if not more, than all the other alternatives. They can restore only what is missing. Our cavity forms do not have to be great and precise and geometric. They could be used for small-term, long-term, transitional restorations. Yes, cost is a big factor. They are much, much lesser in cost if you compare it to indirects. The bonding is always cohesive. The potential fractures are always repairable. It fulfills all my concepts of biomimetic, bioactive, and bioaesthetic concepts. Well, when we talk about resins, the first question that has popped every time that we talk about composites is, oh my God, composites don't work. And why? The first thing that hits our head is sensitivity. Well, composites were not designed to make the tooth sensitive. It was the wrong technique, the wrong handling which made the tooth sensitive. Then we talk about adaptation. No, it's not as hard as amalgam. I cannot pack it. We can pack. We need the right instruments and the right technique. Oh no, composites crack. They create too many secondary decays and micro leakages happen. No, they don't. Handled well, it doesn't happen. Oh, it changes color, it stains. Okay, polished well, it retains color for a long, long time. Trust me. We all know these phenomena. We all know the C factor, the configuration factor, which says more the number of walls, bigger will be the shrinkage. And trust me, friends, this C factor is the root cause of all problems, but it has a solution. The shrinkage that causes micro leakage, cuspal flexure, the shrinkage which gives post-operative sensitivity, gaps, tenderness post-op work can all be tackled and managed. All we need to understand is the configuration of the walls does not have to be geometric. It has to be a scooped out cavity. And secondly, how we are going to and where we are going to put in our reinforcements. Well, the first problem that we always face is stress concentration. There is shrinkage, which is not a botheration to me. Trust me, polymerization shrinkage is an inherent problem with composites and it can be tackled. The problem is shrinkage stress. That immediate pull that happens, we have to just cushion that. That causes immediate debonding, that causes immediate post-op sensitivity, delayed post-op sensitivity, cracks at the margins, cuspal flexure, etc. And then the margins give up finally and we start having decay. Nowadays, there are a lot of bulk composites, and I also use some bulk fills, but not for enamel, only for dentine, and I don't prefer packables, I prefer flowables. But if you have a bulk composite and you cure it, either of the wall will show shrinkage. And when they show shrinkage, we have gap formations. Now, what causes these gap formations? It's not just the shrinkage. It is more that the immediate stress that the material got pulled by. And that is why equally or more important is understanding how to minimize the stress of shrinkage. How to make sure that the bottom layer, when it's getting cured with the subsequent top layers, does not create that pullback. Because bulk place composites will show signs of this shrinkage and we will have adaptation issues. Occlusally, the restorations will look perfect, but look at what happens here at the margins. The margins all pull up, and this is what causes the biggest trauma on the tooth. The pulp undergoes stress, there is movement, there is micro movements happening inside, bacterial contamination, it is pumped to the pulp tissue, and we're looking at a potential root canal treatment, if not a crack before that and an extraction. Whenever such things happen, always remember the tension cusps, they take a lot of load. And I'm always hinting at stress, at tension, because the reinforcement that we practice and that I'm going to suggest has to be decided, the placement has to be decided more on the floor and on the tension cusps. Because compression rarely breaks, it is the tension, the flexure which breaks. Now, when we have a deep cavity, we have these areas where stress gets concentrated. And when these areas come under occlusal loads, the same areas start propagating the stress to the outer structures, and finally we have cracks and fractures. Now we have a huge depiction of a composite restoration. The stresses act on the area where we have more tension. The micro cracks add to the trauma, and finally we have a tooth which is broken. If we are lucky, it's a subgingival fracture or an equigingival fracture. If it goes below crestal, we may end up losing the tooth. Now these break. I'm not questioning that they don't break, but why do they break? Improper cavity form, too much of tooth reduction, and most importantly, wrong occlusal placement. Always make sure that there's never a junction where your opposing cusps are touching. They should ideally be resting completely on the tooth or completely on the restoration. Now I've told you all the problems, now let me give you the solutions. Coming to the biomimetic concept first. This is how a tooth is, and that's how the stress is transferred from the tooth in a normal situation to the PDL and from the PDL to the bone. Now, what causes the stress transfer is not just the enamel here. It is that soft DEJ, the gradient which absorbs the load and then pushes it so that it transfers along the dentine and the enamel layers to the root. So we need to have that cushioned DEJ back. If I ask you which of these two pictures shows most stress concentration, obviously the heel, not the flatter rounder structures. When God made teeth, they created domes, they created a scalloped DEJ. That was a multi-scale gradient that God gave us, the DEJ, the furcal dome, and the flexibility of dentine, which is elastic, and a lot of collagen, which makes it so flexible so that whenever we bend, they bend like fibers. And that's why fiber reinforced composites are an important mainstay. They are my main workhorse in my practice. Now, where do we reinforce? If at all we use something, and I'll show you a fiber, how we use it. But where do we reinforce? You could reinforce when you're doing crowns. So during the buildup of a tooth, we can place 1 or 2 layers. Or if it's a cavity, we can place it at the line angles and the cusps which are taking more tension, so that their reinforcement pulls and strikes it back. Now, if you do not have a reinforcing layer, a soft, a cushioned layer, the stress directly goes down to the furcation or the bottom layers. But let's add a small net in between. It's like a cushioned net. Whenever there is forces, the net goes down. It's like a cushion you're sitting on right now. Whenever you sit, the cushion gets depressed, but the load is not transferred to the base. As we get up, it rebounds. And that is what is the entire focus that we have to lay on when we talk about reinforcing restorations. I'm going to discuss in brief about a fragment of a figure which comes from a company called DentaPreg. I've been using it for about 4 years now. Before that, I was using other fibers, and I will show you why I shifted to these ones. The name DentaPreg means dentally pre-impregnated composites, which are fibers. It has a lot of uses that you have, right from splinting to making pontics. You just saw Dr. Rohit showing you a bridge replacement. The first time that something struck me hard was a fiber manufacturer providing fibers according to the direction of loads. So when you see it is an SFM, it is a splinting fiber multi-directional, versus an SFU, which is a splinting fiber unidirectional. Similarly for pontics, if I have an anterior pontic that I have to recreate, I would use a multi-directional fiber. For a posterior pontic, I would use a unidirectional fiber. We have the mesh that I love using, which can be used for a lot of reinforcements. And we also have fiber pins. I'll briefly show you what they are capable of. So the first set I'm discussing is the fibers called the universal fiber multidirectional. It's a mesh. This is a highly microscopic or a magnified picture, where you see this glass mesh which is interbraided, intertangled, it's stretchable. The best and the most important aspect of these fibers are they are pre-impregnated with the adhesive. So we do not need to do any surface coating. It makes a lot of difference. The previous fibers I used to use, without taking names, I had to pre-impregnate or probably put a bonding coat on top. Here the adhesive is pre-impregnated. It's sticky, it's nice to handle, it adapts really well. Because it's glass, it's not polyethylene, so it's flexible, more flexible, and can incorporate high number of fibers in a small little area. It's ultra thin, it's 4 by 10 mm in length. You could cut it, it's available as an 8 centimeter strip. You could cut it to the amount you want to use. A strip is good for about 10 to 12 cases, which makes it fairly economical. Comes in a light-proof pack. Make sure you remove whatever is needed, cut the right amount, and put a light-proof pack. To rehabilitate a tooth. Now, this is the concept which is actually called the biomimetic concept, where we try and create the flexibility of dentine. Now, I layer the first base with a flowable composite, about 0.5 to 1 mm. After that, I do not cure on top with subsequent composite layers. I put this elastic mesh on top, like a U, like a scoop. So I'm changing my C factor right now. I'm reducing the contact of my further composite to my walls. And the U shape, the scooped out shape, doesn't give you desired geometric walls. It gives us a cup-shaped structure, which has a very less C factor as compared to 4 walls. If you're doing big restorations, one layer could be going on the base. The second could actually replicate the DEJ, the dentino-enamel junction, the flexible DEJ, on which we can build up a direct tooth, which I love doing. I love doing freehand build-ups. You could do an onlay, an occlusion VD, or you could also give a crown. So this is the decoupling technique that I've been practicing for a long time. The first time I read the word decoupling was in year 2000, 2001. When we and my dear friend Dr. Deepak Mehta, we were batchmates in post-graduation, we got the concept of breaking the junction between the two layers, because the moment we do that, the bottom layer doesn't pull up, it stays. So the chances of micro cracks, the chances of micro leakage, and the potential pulpal stress is totally negated. We started with bifluoride varnishes, we used a lot of glass fibers, polyethylene fibers, and finally now we're using the Dentaprec fibers for all the obvious good points it has. When we place that on top of that primary 0.5 to 1 mm layer and cure it, because it's pre-adhesed, it attaches to the composite and the pull of the curing gets down. So more force is transferred towards the pulpal surface than away. Now, there are two ways of doing it. Either break that continuity by using a mesh, or wait for about 5 to 20 minutes so that the polymerization is complete and the top layers cannot cause this problem. But the second choice is a little difficult, considering under a rubber dam, the patient is opening the mouth for 20 minutes, not possible. This is a photograph from a very dear friend, Dr. Akshay Sharma, an excellent clinician and a certified biomimetic dentist. And this is exactly how he demonstrated the use of a UFM fiber. See the scooped out shape, attachment to the walls, and transferring a 4-walled cavity to a C-shaped or a scooped out cavity, totally negating the C factor. Why only posteriors? Why not anteriors? We have a lot of problem, class 4's fracture, they fail, they cannot take the loads, and we end up doing crowns. Well, we could use the same mesh and reinforce, either using the pulpal chamber if you're doing a non-vital restoration, the same braided mesh, or we could incorporate that mesh between the palatal fragment that we create, the palatal floor that we create, and the rest of the body. Now, the question that one needs to ask here is, if I'm putting a glass mesh, will it not hamper the aesthetics or the final color outcome? Well, friends, the answer is absolutely no. It's glass and it's transparent glass. It cannot contribute to any color change. You can just adapt it on the palatal layer, and on top of that, do all the classical buildup that we know of. And there will be extremely, extremely good restorations and also strong. So it's easy, it's strong, it's safe, beautiful aesthetics because of the glass, and very, very cost effective, because one strip can be used for about 10 to 12, 15 uses. Now the question, why I chose to use this over the others. What we classically see, the tensile strength of fibers have been low. And that's why we always have problems with fibers, they crack, they break. But look at the tensile strength. The two golden players, Everstick by GC and Dentaprec. Everstick has a good range, but Dentaprec is even higher. And not just the tensile strength. If I incorporate that within a restoration, the bending fracture, the fracture to bending forces is much, much higher. No reinforcement is rock bottom. Reinforcing with a UFM, look at how much kilojoules per meter square. As if you're hammering the tooth and nothing goes wrong. Not just these meshes, we also have pins to replace the classical metal pins. We have glass fiber pins, which can be used to replace line angles, to replace missing tooth structure, to reinforce, to give more resistance form to the structure, both micromechanically and by bonding. We could use them as lateral fillers when we have an oval canal and a round post. We could use them in canals which are oval as multiple pins. We could use them for reinforcing vital teeth. They're extremely flexible, very low modulus of elasticity, mimicking absolute dentine. And the more the number of pins, the larger the surface area, the better the force distribution. So if it's an anterior tooth, we can always place pins at line angles. You don't need an extensive armamentarium. Any tapered needle burr which can go 2 millimeters into the tooth. Use a flowable composite. You can bond this pin, and on top of that, you can see the restoration here. The pin does not hamper the aesthetic value at all. The best part is, as Dr. Rohit Shetty already stressed, these flexible glass fiber pins, they do not have that disadvantage of the traditional metallic or the hard posts or pins. These are totally non-invasive. We don't need extra preparation, and especially in the era today where we are doing a rotary endodontics, where we already have tapered preparations, 4%, 6%. We just need to clean the canal of the gutta percha, and these pins could be placed one too many inside the canal with a suitable luting dual cure adhesive material, and we have a good post and core ready. The force distribution being fiber, being low modulus, being totally bondable, it creates a monoblock. So as I said, you don't have to do too much of hard work. Just clean the canals from where the pins, the gutta percha was placed. A 2, 3, 4% taper is good enough. I prefer a lot of dual cure resins when I'm talking about bonding such pins. My personal favorites would be the Luxa core from DMG or the Fluoro core from Dentsply Sirona. And just keep on placing pins as many as they go. They may just keep on coming up. Once done, just remove the excess and cure it. They're light transmitting pins. Being glass, complete light transmission is guaranteed. So you also have a better cure at the base level. Now we can use a flowable dentine material. I'm stressing on the word flowable dentine material, something like an SDR or an Ivo Flow by from Ivoclar Vivadent. Always base your materials with a dentine flowable material. And now we can place the mesh on top of that. Now see here we have recreated the flexibility, the tangency of a DEJ. At the same time, we have given a dome safe structure for force distribution. Just quickly running video how we are So if we can actually see here how the pins have been spread out to have the load bearing areas at the 4 line angles. Because usually what happens, a post is in the center and a lot of unsupported core goes outside. Here we have pins on each corner of the tooth so that the force that is coming from the top gets translated to the bottom and finally just dissipates. The only word of caution is we should not leave the pins exposed to the occlusal trauma. So always layer it with more composite, more dentine composite, and then decide to give an onlay, a crown, or an OVD, whatever one prefers. So just to show you how easily and how simply it can be placed in cases where you have too many differences in the canal anatomy. It's an oval canal premolar. So rather than preparing the oval canal for a round post, we have respected the anatomy and placed 7 to 8 parallel pins with a lot of luting material to create a monoblock. So just some examples that have been done where we have worked with these pins. They look like a quiver of arrows, but eventually they look like a solid restoration. You could just build it up completely. And that's how we reinforce our teeth. But when I talk about reinforcement, these are the ones that reinforce the base. This is like the metal rods that go in a foundation of a building. But they alone cannot sustain the loads. We have to cap it with a strong material. And when I say strong, I'm not talking about only hard. Strength for me is resilience. For me, a rubber band is stronger than a pencil. A pencil may be hard, but a rubber band is elastic. Again, why, when I said elastic and resilient, why my resins available today fulfill these criteria? They can be used in every aspect, class 1, class 2, class 5, all the classes for build-ups, for splinting, for post and cores. They're easily visible on the X-rays. The shrinkage is very low, and we can negate even further by understanding light curing and standing placement. They're compatible with multiple bonding systems, very user-friendly, and the best part is it's repairable. All companies have this. The only problem that we as dentists have, we buy kits, and the kits, universal kits, are never either enamel or dentine. Because any universal composite would be maybe enamel or maybe dentine, more so they're enamel. And enamel is supposed to be hard. So if I put a hard material on my reinforced base, the base is going to crack. Look at this. This is a company called 3M. They have dentine, they have body, they have enamel, they have translucent. Both histologic and aesthetic. Dentsply Sirona. They have universal composites which can behave like enamel, which is the ceramics one. They also have composites which behave like enamel and dentine separately. Dentine for dentine, enamel for enamel. We have fiber reinforced composites by GC called the Everex. We have flowable dentine material like SDR and like EvoFlow by Tetric. We need to choose the right armamentarium and the right material. If we have to restore a class 4 defect, for example, even after when we have put in the mesh, the concept that Dr. Daishi gave us of a 3 or a 4 layer concept, it requires an opaque material, it requires a dentine or a body shade, and it requires an enamel shade. Now people say putting too many composites makes it difficult, but who said life is easy? The moment you make your difficulties easy, the journey from an average clinician to a master clinician starts. Why only anteriors? Why not posteriors? We need a flowable dentine, a cushioned dentine. We could extend with that after we place the fiber, or we could place a packable dentine if we need to create stains, and then cap it with enamel. How difficult is that to follow what God told us? Just create the natural anatomy. We have so many dentine replacements available. As I said, SDR, smart dentine replacement by Dentsply. Actually, this is one of the a unique material available in the market which stands not for smart dentine replacement truly, which stands for stress distributing resin. It has a cushioned monomer inside it, which tackles not just shrinkage, but shrinkage stress. Or we have fiber reinforced flowables like Everex Flow. Now, I personally would like to put in a fiber which acts as a mesh rather than incorporating it at every level. Just to show you the advantages these flowables have.
SDR, Smart Dentin Replacement, the only bulk fill self-leveling posterior flowable base. Begin dispensing at the deepest part of the proximal box. SDR not only adapts to the matrix band, but to the internal anatomy, including the sharp corner of the proximal box. As we move across the prep, the material is not pulling or dragging, but moving along with the copula tip. After placing the material up to 4 millimeters, it quickly levels to provide a smooth interface to adapt composite to. Even when you're performing maxillary restorations, to demonstrate, a human molar was prepared for a large Class 2 restoration. The tooth was cut in half and adhered to a standard glass slide. A matrix band was placed to seal the proximal box. The glass slide was positioned at a 45-degree angle to mimic a maxillary restoration. Begin dispensing at the deepest part of the proximal box and watch as SDR self-levels and adapts to the corners of the prep. After dispensing up to 4 millimeters, SDR remains where placed and does not slump or flow out of the cavity preparation, making it ideal for use in maxillary posterior restorations. Self-leveling and bulk fill, a revolutionary posterior flowable composite any way you look at it. SDR, Smart Dentin Replacement, the only bulk fill self-leveling posterior flowable base.
So friends, why I prefer this material is exactly the last line that you heard. It is one of the only self-leveling materials. So if I go wrong somewhere, I pull it faster, I will not incorporate a gap or a bubble, my material will pull back and adapt very nicely. But all said and done, all the companies that claim that it could be cured to 4 mm and 5 mm is done under absolute test conditions. My clinical request to everyone watching this is, if anyone says it could be cured to 4 mm, please try and do not go 4 mm, try and go 2 mm, max 3 mm, because they do it with the best material possible. And I don't remember last time when did we get a light cures tested. So we have to build in the variable of clinical problems when we do such work. So please, if a company says 4 mm, do 2 increments at a time. Do not go more beyond 2 mm increments. Just to share a small quick review of the materials that I've showed you, a case was referred to me by a fellow orthodontist. A root canal treatment was done for this particular tooth and they wanted to start ortho treatment. They were reluctant to give a crown because bonding to a ceramic or a metal may be questionable on that day. And if you look at the clinical crown height, there's nothing left for us to prepare so that I can go ahead and give a crown. The patient was very, very scared when we talked about surgical crown lengthening. The moment I used the term surgery, the girl was petrified. So we had to do something so that the orthodontist could place his bands and at the same time we give a structure. And remember how I started. We did do some experiments to start with, but today those experiments are a full-time protocol. We removed the entire old filling, isolated the cavity. And if you notice here, we have done only gutta parcha removal. We have not removed or made two big post preparations. The side where we had the line angle missing, we have placed 2 pins in a canal with the help of a dual cure material. With the base with SDR, I incorporate my mesh. This is where I place my mesh. That's exactly what I mean by decoupling. My mesh is completely incorporated into the flowable now. And now when I put the subsequent dentine flowables, the elasticity of the mesh is going to make sure that my bottom layer doesn't pull up. And that's how I built it up with enamel. The patient was fairly happy. The orthodontist was fairly satisfied with the results because that's the kind of occlusion we gave them with a direct build-up. And now the question will definitely pop up, what if it breaks? Well, anyone who has this doubt in mind that a big bulk composite restoration breaks, when you get back to your practices tomorrow, make a small ball of composite of about 2 millimeters, cure it nicely and stand on it. And you'll have the answer. Composites do not break under compression very easily. They're very strong. Now, just changing the band from restorations to a little regeneration. You already heard Dr. Rumpavik talking that day about the bioactive materials, the Activa. So I will not take much of time, but just to tell you, probably in my practice, where and how and why we use bioactive materials. Well, I read this long way back in 2017, Jack Ferracane gave this deliberation, which said that why not reverse the process that we are doing? Why can't we just heal? Why are we only sealing? Let's start rebuilding the strength from the tooth. Let's provide immunity to the tooth so that the tooth becomes strong from within. And that led us to experimenting and researching and talking and discussing across the world. And finally, I've been using this product for a long, long time now. My clinical use probably first time I used was when FDI was held in India. I was gifted this material generously by Miss Mala Malik from M&M to try. And I've been using this since for a lot of my restorative needs. It's a 5-star rated product. And the best part is people who are scared of resins. This is a no bis GMA, no BPA derivative material. It's moisture friendly. And the best part is not only fluoride, it releases calcium and phosphate ions too, which are a mainstay of our hydroxyapatite, which says it stimulates or regenerates the hydroxyapatite and prevents further damage. The best part about this material is, whenever there is an acid attack, onto your screen, green part is the demineralized part. So whenever there is a proud acid attack on the demineralized tooth structure, within or outside, the bioactive resin as a reservoir infuses the calcium, the phosphate, and the fluoride, reinforcing, rebuilding these complexes and making the tooth strong from within. This resin is a special resin. It's a rubberized resin. So if you're not very fond of SDR, or if you're not very fond of a soft composite, this is another alternative. On bending tests, it has shown signs of deflection and getting up. This is a very unique property this material has. The rubberization gives you a lot of stress absorption and dissipation, not stress concentration. So when you look at this material, it has been probably been tested for a lot of things. Remember the deflection, the bending forces that I was talking with the fibers. Exactly the same concept reinforced. The deflection breaking is very, very high as compared to regular composites, leave alone glass ionomers. It's tougher. When I say tough, means more resistant to fracture and breakage. The rubberized resin, because of it doesn't abrade, it compresses, cushions, wear is very little. And this material is self-adhesive. Yes, if you have a non-retentive cavity, if it's and I'll share a case, if the cavity is open like a crater, we need a self-etch adhesive. But in a class 1 or class 2 where we have retentive boundaries, we do not even need to use the etchant or the bonding agent, which itself reduces a lot of heartache of sensitivity. You've already seen Dr. Rumpa share this, but I love showing you this. It does compensate for a lot of other things that we don't have in a lot of other materials. The option is plenty. We have base liners so that you can create a bio base if it's a deep restoration. We have a bulk fill material which can be filled in bulk. We have a similar philosophy for kids and a cement for bonding our crowns. Available in different shades and fairly easy to use. All you have to have is a dispensing gun. Just bang, go into the tooth, fill it in bulk, and you can create the occlusion later. So just sharing a case, this lady had a fractured restoration. We needed to remove the old one and do a new one. But if you look at here, we've not given any cavity form, any cavity shape. Yes, because there was no retentive feature, we used a self-etch adhesive. And that's our final restoration. This case is about 1.5 years old now. And a lot of people argue that when you have put a base adhesive inside, then how will the ions diffuse through it? Well, friends, the bonding agents that we have today have a hydrophilic as well as a hydrophobic end. So the hydrophilic part of the bond, the hydrophilic nature of the tooth, and the hydrophilic nature, the water-loving nature of this material, all combine, and whenever there's any acid attack, the ions will diffuse through. So that's your pre and post. Dr. Rohit shared a case with you of his sister, and to share that incident, we all were there when he was working on his sister, and we saw how the magic translated. And Dr. Pallavi rightly said, if you could trust it on your family, you could trust it on everywhere else. So I'm sharing this case with you. It's not my sister, it's my mother's case. And okay, sad, it's a dentist's mother case, but she came to me with this problem. And if you notice, look at the kind of cracks we have. If I try to do a cavity prep, I'm definitely going to break the tooth. Trying to give a crown, the cracks will propagate, we may have a disaster. I may not want a crown on my mother's tooth. So how did we tackle this case? All I did was removed all the weak enamel. Again, the cavity is non-retentive, shallow, scooped out cavity. Cleaned it nicely with chlorhexidine so that we have no bacterial contamination or as minimum as left. Sealed with a self-etch adhesive, and there goes Activa. Just trying to mimic her stains, I have put some brown color on top, but that's negligent. You may not put it. That's the tooth in occlusion. And my mother has been, I usually say wearing this restoration, I don't say using. She's been wearing this tooth for more than 2 years now. And touch wood, I always touch wood. I don't want my mother to hit me at this age because I broke a tooth. But yes, it's working absolutely fine. Thanks to not what I could do, thanks to the kind of philosophy we have been following for a long time. That bulk fills, if completely encircling the occlusion in a full contour, they do work and they work wonderfully well. So that's a whole compilation of the Activa. You can see it's a very easy material. Just that, and I'm showing you all the cases which had non-retentive preps, wherein we had to use the self-etch adhesive, and we've come out with wonderful results for a long, long time. The good part again about this material is, as with composites, it's repairable. We don't need to remove completely. It will attach to its own if we give it a decent form. a material which is not yet launched in India, but yes, for the people who do not still trust no bis-GA, no bisphenol, this is a light cure composite, which is a bioactive material, the Activa Pronto, soon to be launched in India by the same company, Pulden, through M&M Dental in India. So these materials, they're very easy to use in day-to-day clinical practice, and they're very effective. But having now discussed about the direct part, let me now just conclude probably the later half of my presentation by something which you would read the word and you will know why me, Dr. Rohit Shetty and Dr. Deepak Mehta absolutely bond and gel together. Is yes, we love each other too much. We are friends and friends for a long time. But our bonding agent has been the bioaesthetic concept, the Edelweiss concept. You've already seen him showing beautiful work. But as he said, and because I never say no to Dr. Shetty, he's always been telling me to do what I have to, and I always listen to him like a good boy. He said you will conclude with extreme rehabilitations. So let's just see some extreme rehabilitations. But before showing you this material, as a clinician and as an ex-academician, and I still do a lot of outside college academics, I just do not trust a material because a friend referred or because it looked beautiful. I see the reviews, and what better than reality and CRA newsletters. Now look at this. Look at the 5-star rating. I'm not demeaning any other material here, but none of these other materials stand close. This is when it comes to the material that is used to procure it. Then comes the composition, the sizing. Again, 5-star rating as compared to all the other materials. When compared to shade matching, when compared to shades available and visible, again a 5-star. It follows the skin concept. What you put inside shows outside. And long-lasting luster because of the unique laser sintering glass infiltration process. So let's quickly run through some cases where we were scared and we came out really well. Now this is a dark tooth, a dark black tooth, and the shadow itself is explaining inside is not going to be easy. So the first thing that we did was, and we always practice this philosophy, we always make a putty index before we do any removal of the old filling or the old restoration, because recreating the same palatal aspect may be tough if we do it indirectly or even if we do it looking into the mirror. But this palatal index gives us a best substrate to hold against. I fitted the palatal index, and now see what happens. When I remove, when the carious part was removed, there's hardly anything left. We all talk about ferrule. We talk about the vertical height of ferrule. And at least as a restorative dentist, I realized just the vertical height does not matter. The width of ferrule is equally important, which we do not have here. Which says if I do a post-core and a crown, I may end up probably breaking the crown at the cervical margin. Because I may have to prep more, I may weaken the tooth further. So how do we try and tackle this case? There were other small class 3s and a veneer on the adjacent central incisor. So this is how we tackled this case. We built the entire structure up with some pins inside the tooth with a dentine, a suitable dentine material, because the color, the chroma has to come from dentine. The beauty is from the dentine. Enamel only showcases it. We trim the veneer according to the shape. You've already seen how Dr. Rohit Shetty showed you. We can internally characterize, we can create striations, we can give pericymata, we can add colors, white stains, brown stains, blue stains, the radiolucency at the edge, the flakes of white fluorotic spots, everything can be added on the inside. Look at how thin we could go. This is thinner than probably something I could imagine. But the important part is once bonded, the strength is very high. Apply the veneer bond, which has to be used to activate the cured composite. You saw the video, or if you did not see, this composite is 100% cured outside the mouth. So to make it reactive, you need a veneer bond to bond it to the tooth. It gives you the luxury to choose the color. You've taken a shade guide, you've chosen a color, but here in this case, we matched the color, but we also gave the patient a brighter option. So if you choose two pictures, one has a darker color, a more subdued color, one has a bright color. The moment we showed the patient two options, the patient on their tooth chose obviously the brighter color. We went ahead, you've seen the sequence, how the mylar strips are used. Tack cure it for 2 seconds, making sure the proximals are not exposed. Now you can add or subtract at the proximals if you need to. Cure it from the sides. Make sure you use the mylar strip to completely enroll it. so that the composite completely encircles or flaps against the tooth. The composite is not going to change shape because the veneer is going to guide extra or lesser composite. That's a post-op palatal view. And that's how we could end. This is a long old case. This is more than 4 years old now. Coming to the second part, the posteriors. Remember I was talking about the strength of a tooth, the modulus of a tooth, etc., etc. First of all, look at how beautifully the occlusion VDs have the natural occlusal pattern, the cusp to fossa relationship. They're not very thick. That says you do not have to prepare too much. In fact, we can reduce this further on the internal aspect, not on the external aspect. And now comparing it to nature, the compressive strength of the VD is 550 megapascals and enamel is 384. The flexural modulus is 19 and the dentine is 18. And that's why the tagline is the difference of this material is in its similarity with nature. Comes in different sizes. You can choose the mesodistal width and the size accordingly. Whichever dentine material, categorically dentine composite, packable dentine composite has to be used to bond this to the tooth. Please make sure the physical properties are same. It should be about 80% plus filler load and the megapascals should be more than 150 to 160. The compressive strength should be at about 480, 490 megapascals. So just quickly taking you through the steps in a video form, where you see how badly broken down teeth can be restored back. And that's a disaster over here. Old amalgam, the tooth is broken. So we remove the old amalgam, do a base restoration. And now look at the beauty of this occlusion VD, that we can trim it to the size of the tooth. We don't need to cut the tooth to the size of a crown or a veneer. We can vice versa prepare our restorations to fit the tooth. Till now we were doing tooth preparation. Now we are trying to do restoration preparation. So the same steps, you put a veneer bond, you cure it. So that's the first step. We do not apply the etch and bond on the composite, on the tooth area. We just put a little ball and adapt the occlusion VD on the tooth and request your patient to very gently close. Don't ask them to crush. Very gently close. This gives us the arc of closure as to which side it is tilting, which side it is not. So the compression cusps always take the load and they tilt towards that. Cure it for 2 seconds and pull it out. Now this has given us a stent, a key, how this can be fitted into the occlusal screen so that it doesn't move. Now we go with the conventional etching bonding. I really love using the wedge guards by Paladin V3 here. It's available by Dentsply Sirona. These wedge guards, they separate the tooth and allow us to bond the VD without the composite attaching to the adjacent tooth. So now we take more composite. Please make sure if you're rolling it with your hands, your gloves are clean, sanitized, powder-free. You could rub your hand with a sanitizer. We all are doing that these days before we use our hands. Else, dispense it directly with a gun onto the occlusion VD and tap it nicely. Use a soft instrument like a smile line or an opera sculpt pad. Just stick it on that plastic filling instrument and take it to the tooth. One of my personal favorite instruments in restorative dentistry overall is this, the opera sculpt pad. It's a small pushing padded instrument with which we can apply force, we can contour. It gives a nice polished surface and a good adaptation. So we do the initial cure for about 5 seconds so that the surface gets cured. And now we can remove the excess. So if you see, we're trying to trim off the excessive composite. Finish the proximal margins. You could use flexible metal strips. Sometimes when the bond is too strong, we have to use the thin metal strips. Brasseler has beautiful interproximal strips available. Even Cosmedent has beautiful strips available. Now we go ahead and check the occlusion. If our pre-trimming, if our pre-adjustments are good, the occlusion trimming is very, very negligible. But please friends, I am using this word again, it's a vertical dimension, occlusion for vertical dimension. Where we have lost the vertical dimension, use it. Please do not reduce the vertical dimension because we have to do this. You can do with a simple composite restoration, the ways, the likes we have already seen. The best part about this restoration is all the changes can be immediately finished and polished. A 2-set glass polisher, a green and a grey is available. You could use goat hair brushes to give it the high luster possible. And that's how we end up with a bioactive, biomimetic, bioaesthetic restoration in the same day without causing too much of a trauma to the periodontal. We did not cut the pericervical external enamel, internal dentine, and we have the function there. So this is how we probably can go ahead. And the last that you've already seen, Dr. Rohit showing you the Edelweiss post-encore. So showing you my part of the extreme rehabilitation with this laser-sintered post-encore. Completely kind of a dentine replication. The modulus of elasticity is same as that of dentine. It's completely bondable. It gives you a true monoblock, a primary monoblock. And it absolutely cuts like dentine. The light transmission is inarguably the highest amongst any glass fiber posts. Available in different shapes and sizes. So when the first time this case was referred to me, 2017 March, was when I had recently started using this concept. And a friend who saw one of my presentations said, now let's see what you do with this, because we're going to extract and put an implant, delay the extraction as much as possible. So it was a request, in brackets a challenge. I saw this case, I said, okay, fine, come tomorrow, let's work. The patient got so confident that I'm saving this broken tooth. Next day when she came, when we had to check what we had to do, this is what I see. Only an enamel cuticle kind of a structure left, rest everything gone. Friends, I took a written consent that if this breaks, you will not sue me for any damages and you will have to pay for the extraction. Patient was absolutely agreeable. They wrote a consent that if anything goes wrong, we are not to be blaming the clinic or the practice. So we could take a chance. I used the molar post. We have the molar post. The dimensions are available here. I used a small molar post. I bonded the monoblock post. I created my entire structure with SDR, and everything is happening on the same day. I put my wedge guards inside. I etch and bond the tooth. I select the right size, and I bond it. Simple story. And I tell the patient, please, the moment it breaks, come back because you need to get an implant done, and this is only for soft tissue contour, and we have only retained the roots for a longer time. The patient went out like this in proper occlusion. So we did not infra-occlude so that the forces do not act. That was our immediate post-op. The little bleeding you see is because of the trimming we did on the proximal and the gingival margins. That's the palatal aspect. So that's how the patient left. Only to come back 6 months later like this. So now I get more confidence. I'm thrilled. I keep it as a recall case. That's a 6-month post-op. Now let's see what happened 12 months later. That was immediate. That's a 12th-month post-op. So now I decide to polish it again a little so that it looks beautiful. That's 2 years later. Friends, this was done in March 2017. Coming March, it would be 4 years to this extreme rehabilitation. Why only posteriors? Look at the anterior. The arch that you see here, this tooth has been completely built up with composite and indirect and semi-direct methods. Removing the old caries, this is exactly what we are left with. So we follow the same concept that you've seen. Try and restore for as long as possible. The post drill goes in. We try the post. And the best part is you do not have to have a 14mm long post, because here the retention is not frictional, it is not cement based, it is bondable. And you'll notice here we are trying to do a completely bonded procedure here. We're mixing the self-cure adhesive or the self-cure activator with the bond so that it becomes a dual cure. And this is a flowable composite. The best part is we're using a flowable composite which matches the chemistry and physics of this material. We create and modulate the gaps with the same material, creating a 2 monoblock. The light transmitting post-10 core lets us completely transmit. We apply the veneer bond again on the top surface. And now with the old palatal index, you will see a complete tooth reformation on the chair, and the patient is frankly happy. And people ask me, do they break? My personal recalls are not very long. I've just probably been working for a little around 3.5, 4 years. But I've seen the recalls at Edelweiss in Austria. We have more than 12 years of clinical recalls wherein patients are absolutely happy and thrilled. There's nothing that has gone wrong, because the concept here is not trying to give an extra material. The concept is not cementing. The concept is not interfaces. It is bond which completely stabilizes the tooth structure and gives you a monoblock right from top to bottom. And that's how we could complete the case. With all the stainings and all the materials needed, you could see the top two pictures to see how this beautifully result has been obtained in a very little time. And I always tell my patients and also my colleagues and friends who ask me, you spend about 2 hours on a patient. Well, I spend about 2 hours on a patient. I don't spend 3 visits on a patient. And my patients go back happy. I am satisfied professionally and financially as well, because I earn the same in a visit that probably I would be taking 3 visits to one. So just to show you what this extreme rehabilitation can cause, I know I have completed my time. I'll just take another 2 minutes. So I request the organizers not to shut me off. No, that's
I am Nikhil Bahuguna from India.
I wanted you to meet this gentleman. He's the guy who has developed this post-10 core system. So this Edelweiss post-10 core system is an Indian innovation.
To introduce a new concept for post-endodontic restorations. This idea to make post-endodontic restorations more predictable, more simpler, faster, and easier. This direct system of Edelweiss post-10 core works very easy. I mean, everybody does post-endodontic restorations using glass fiber post and composite core build-up materials. But then we need to find a solution which makes our job much easier in clinical situation, where we have a single piece post-10 core which has already been prefabricated, pre-silenized. So you have the post with you, you have the core with you, and in one step you just go bang into the canal, and it makes your job much easier. After you prepare the post space, you do the trial fit of your post-10 core. So then you go with the etching of the post space, wash it thoroughly. You apply the adhesive, light cure it. Then you go with your core build-up material if you want, or you can use your composite resin cement and just go in one shot, loop it, and then you are done. And then if you feel that you would really want to add some composite, you can do that very easily, because as I said, it is customizable. But this will make your job much easier. At the end, I want to say that this is a new solution, it's a new tool for all of us, which makes our endodontics, post-endodontic restorations much easier, faster, simpler, and more predictable. And it has many advantages because it gives you a true monoblock effect, because it's a complete composite post-10 core. It's easy to trim, make your patients happy at the end of the day, and most importantly, you go happy from your office.
So that case, whenever I see, it's like the mother of extreme rehabilitation. So someone who came in like this, with a face which was pretty but not confident, goes back with an absolutely amazing and a stunning smile. Well, that completely concludes and explains my trust in the material called restorative resins. And all that I showed you today is only resin-based technology. They're all composite resins in one form or the other. Well, we were having this discussion and Dr. Rohit started with this, and I'm going to probably, as I end my lecture, I would say this: always remember, dentistry is an art and science. That is what we were told. But I would like to rephrase it. It is an artist's science. And remember, do not, if I say something, you should just try and use it. Try and work on it. Do not shun anything because you don't like it. Educate And let's educate others about the different philosophies. And as again said, we are not here to replace crowns. We're not here to replace conventional restorations. We are here to give more and more options so that if one doesn't work, the second will work. We'll always play this game before I end my presentation. Let's call A is 1, B is 2, C is 3, and so-called Z is 26. What gives you the edge in life to be what you want to be? If you consider luck, L-U-C-K is 12, 21, 3, and 11 is 47. Skills is 82, knowledge is 96, and hard work is 98. Well, friends, I do not know whether this is a fact or not, but I think English language developed from mathematics. Attitude is what gives you 100%. And when I say attitude, it is not being proud of what you do or flaunting it. It's being compassionate. It's being true. And it's having a heart that if the patient is coming to your chair, it's like your own family member. Because remember, when we go to pray to the church, the temple, the Gurdwara, the mosque, we don't ask God for a Lamborghini. We ask for health, wealth, and prosperity. And God decides to send you a patient as a messenger. So if you do mess up with the patients, we're directly messing with the God Almighty, which I am too timid and tiny for. You'll always remember, if you like it, go for it. Do not let it be. Because if you decide that you have to get it done, you will get it done. Always follow your heart and make things happen. Well, with those few words, that was my journey, 2005. As I showed you, decide and make it happen. I, as a student, presented 4 times at the IST, never adjudged as the best presenter. That was after my NDS. I again did not give up. I got my prize at the best paper presenter. I thought I was happy on that day. Little did I know, 12 years later, I'll again question myself. I'll again test myself to write a 3-stage examination. IAACD is the only body which has an accreditation examination, which is considered over 3 years. And I passed all my 3 years luckily on time, and I was an A-credit member. Later, I was also nominated as a board of director. Today, I'm the national secretary of the organization. So I'm not sharing this story again with you to tell you that I'm happy and I'm proud. I wanted to be standing next to these people who were my idols, and today they are my colleagues. They're still my idol, but I have the luxury to call them up and discuss my cases. Thanks to this journey, 2017, I was invited to take up the membership of the American Society for Dental Aesthetics. And why I always keep on coming back to this fact is that me, Dr. Rohit Shetty, and the smart chap you just saw, Dr. Deepak Mehta, all 3 of us are members at the ASDA. And if the coincidence is not enough, all 3 of us hold the diplomate of the American Board of Aesthetic Dentistry, which in India is only with 4 people. 3 of us and our very fond founder of the IACD, I could call him the father of aesthetic dentistry in India, Dr. Sandesh Maikar. Always remember, friends, work as a team. And today I'm so happy when I'm sitting in the last week of the DRDCA 2020, because this team, Dr. Roxon, again, I would take his name, Dr. Pallavi, Dr. Nupur, Dr. Manu, and the entire group which is behind this work has really pulled off a mega blockbuster. Trust me, this is a feat which probably many years no one will be able to achieve. Well, but my teamwork comes from here. You've already met Dr. Rohit, you've already seen Dr. Deepak, and my senior colleagues, my teachers, my friends, Dr. Sanjay Miglani, Dr. Gopi Krishna, and one go-to person which I always look up to is Dr. Vivek Hegde, and he was my teacher. Though in this picture he looks younger than me, but I have to say he was my teacher. Thanking him and one gentleman who is one of the most politest men I've ever met, but thanks to him, our endodontics is where it is today. Talking about silent Dr. P.D. Joshi. I call him the Bhishma Pitama of Indian endodontics. He has given us everything. So these 2 people I really thank for whatever little I've achieved in life today, along with my friends and my family, my colleagues who helped me. Well, please, dental knowledge is something different. This is important. The only prevention right now is to wear a mask. The vaccine may not come, it may come later. You may get it tomorrow, a day after, or after a year. But the best way you can do is do not lower your guard. Please wear your masks, your protective equipment. If it's not very important to one, please maintain social distancing. And we have enough time to relax. So stay home, stay safe, spend time with your friends, your family, catch up. Nature has given us time to heal, so let's heal back. Because once things are back to normal, I know I'll be running again. Anyone who has any doubts, you could ask me here today. And I have possibly shared everything that I can have as a form for you to contact me. The Facebook pages that we maintain, the Instagram account, my personal professional ID, phone number, my website, anything, any material that we have showed you today. If anyone needs anything, you could contact Dentsply dealers for SDR. You could contact Miss Mala Malik, M&M Dental for Pulp Dent. You could contact Dental Matters Incorporation for Edelweiss and Dentaprec products. So those little words, I would like to thank you all again for being here today and spending your time with us. And once again, thanking the entire team of DRDCA for having me here today. Thank you very much. Concludes my presentation.
So many things in one presentation, sir. Thank you so much for such a beautiful and amazing presentation, and sharing your life's journey. That was the only message I think. One of the messages that I think everybody would have imbibed is keep learning, keep growing, keep dreaming, and you will be there. So thank you so much, sir. I think we can we have question and answer session now. Okay. So Dr. Rohit is also there. So thanks to both of you for sharing this concept. I think a new, maybe a few years down the line, this will be the uh, some new invention, new innovation in dentistry. Change of dentistry will start from here. So thank you so much, and I'll straight away move to question and answer session, sir. The first question to Dr. Rohit, you talked about FMR cases, sir. How to restore the vertical dimension or increase thickness of these veneers, especially in FMR?
Like I mentioned during my presentation, we have two options of while doing the full mouth rehabilitation. We either do the direct technique or the indirect technique. So again, if you want to restore or increase the vertical dimension, we will do minimal preparation. Means like say if it's a single tooth, we would obviously prepare like an onlay preparation and then bond the OVD in place. But in a full mouth rehabilitation, when we want to restore the vertical dimension, we would hardly do any preparation. We would just smoothen out the occlusal surface, and that itself would increase the vertical dimension. And again, we can play with the thickness of the composite that is used for bonding those OVDs onto the tooth surface, which will further alter the vertical dimension. So it depends upon how much of vertical dimension that we are looking, increase in vertical dimension that we are looking at. If we are rehabilitating both the arches, just the mere placement of these OVDs onto the occlusal surface with minimal preparation will increase the vertical dimension. It means, though I mentioned that the thickness of these OVDs are 0.3 to 0.6, we need to understand that they're just not 0.3. They're not monoplane. They're not flat. They have cuspal height. They have cuspal inclines. So when you bond them and develop the occlusion, say if you have bonded them on both the arches, automatically we would have an increase in vertical dimension close to 3 millimeters. And we can further increase the vertical dimension if we so desire by increasing the thickness of the composite that is used for bonding.
Okay, so and so there is no lab step involved in this. It's done chair side, right? Everything.
Yeah, to be honest, in Europe, there's a huge laboratory support, like how we have our indirect restorations like zirconia and metal ceramic that's fabricated in our laboratory. The entire in Europe, they have a practice where they ensure all the customization as well as the relining of these OVDs is entirely done in the laboratory, thereby making our work easier, where we just need to bond them by the chair side on the clinical appointment. But again, right now it's a newer concept in India where many of us are learning and imbibing it in our practice. So the next step forward would be to include our labs as well, where they would do the customization and develop the occlusion, eliminate the interferences, and then send it across for the clinical appointment where we bond it. Right now in India, we don't have the labs involved with these, or even the customization we do it by ourselves. Our clinicians are doing it themselves. But in Europe, the lab has an integral role in customizing these OVDs.
Okay, sir. So I think next step is, as you said, we are waiting for lab to get involved in this. And
Exactly.
okay, sir. Next question to do you, Dr. Nikhil. You spoke about DentaPreg fibers, so there are a few questions related to that. Does DentaPreg fibers need etching?
No, we do not. As I said, they are all pre-adhesed. So these fibers are incorporated with the dental adhesive, the bonding agent. You do not need to do anything with it. Just take it out of the strip, cut it, put that onto the tooth, and cure.
We have to dry the can. That is basic. Drying.
The concepts on the tooth remain the same. You etch the tooth. If it's a post, you
Okay.
dry the canal. That and all is same. There's nothing that you need to do on the pin or even the fiber.
Okay.
They're
Okay.
already pre-bonded, pre-adhesed. So all you need to do is place whichever, if it's a restoration, a flowable dentine, if it's a post space, the dual cure resin inside, and just put the pins and just start curing. You do not need to do any surface treatment to the.
Okay. In case of retreatment, how to remove? Can we remove these fibers easily? Can we do that? These DentaPreg fibers in case of retreatment.
Absolutely. In fact, they are the easiest to remove because they are glass fibers. So they
Right.
can shred. They can shred. In fact, 1 millimeter that you saw, the cross section has more than
Right.
10,000 fibers. So you can take any sharp drill. You have retreatment drills, or you could take an old cutting endodontic rotary file. Just go through it, and it will shatter. The best part of these fibers is we do not do a lot of post-space preparation. So when you're using a thin burr, let's say a small burr or a small drill, it shatters the fiber completely and pulls it out.
Right.
So it is, in fact, I would say the easiest in terms of retreatment.
Okay. One question is, there's a difference in DentaPreg fibers and GC fibers.
See, DentaPreg fibers have a lot of interwoven aligned fibers. See, as I said, GC Everstick is a very good fiber. The only place where I find the edge between GC and this is more universal. It has got different sizes and shapes when it comes to force landing. So it has a multi-directional force landed fiber for anteriors, unidirectional for posteriors in all cases. Secondly, it's available as a mesh. GC fibers are available as strips. So you need to have a better, bigger thickness. Now, the kind of case that Dr. Rohit also showed when he was talking about a bridge, if I have to incorporate an Everstick, my cavity needs to be slightly wider. With this, my cavity doesn't need, in fact, I don't have to have a cavity. I mean, if we can have probably another session on fibers at any other time, I can show you cases that we've done for pontic creation that we've done, for bridges that we've done, wherein the fiber thickness is negligent. A drop of flowable, the fiber sticks onto that. So you don't even need to make preparations for this thing. So it's a much more versatile. I would say give 99 to GC, but 100 to DentaPreg.
Okay. So since you mentioned Dr. Rohit Shetty's case, there was this case of yours in which you used. I would want to ask what is better, to prepare a tooth so that we can give single unit post core, or let the tooth structure or the canal. We should not widen it and we should use DentaPreg fibers. So what is the better option, or does it depend on case to case?
See, if you ask me, I would not say it depends on case to case. It depends upon weakened tooth structure.
Okay.
The amount of tooth structure which is weak and unsupported, we have to remove that. But now, having done that, I will not create a special ferrule or a margin or a shape or a box to incorporate this. The entire concept of biomimetic and bioaesthetic materials are you utilize the tooth surface as max as possible for bonding. So the more the tooth available, the better it is. And these are all 100% bondable materials. So there is no point in creating a shape to add some retention or resistance.
Okay.
So the word here is bond, completely bond to as much as possible.
Right. What is your take on that, Dr. Rohit?
With regards to the DentaPreg over, with regards to the use of DentaPreg?
Yes. DentaPreg and single unit post core.
To be honest, I've basically been using this Edelweiss post core extensively. And with regards to DentaPreg, my experience is very limited. I'll be very honest with you. Nikhil is the best person to tell you with regards to DentaPreg. My experience and my usage is pretty limited.
Dr. Cullen, if I may add, now when you ask, should we prepare a post space and should we prepare the tooth? What our practice philosophy has been throughout and which has been endorsed by millions across the world is natural tooth is the best transfer of load. The more amount of natural tooth left, the better will be the load transfers.
Right.
Probably that is a different answer to the same question.
I agree, because both of you spoke about conserving the tooth structure rather than preparing it. It was not giving up giving a crown. It was always, either giving that veneer occlusal surface also. So it ends on, I think the basic point is we have to conserve whatever we can and preserve the natural tooth. Okay, that brings me to another question, sir. Is I don't I'll just say the question, whoever wants to answer. Is total edge or self edge technique for build up with, I think this is for Dr. Nikhil. Is total edge or self edge technique for build up with Activa restorative for molar build up case? I'm not getting the question. Is
I
total
understand the question. I've got the question. He wants to ask, why did I use a self edge and why did I not use a total edge technique over there? Why did I not etch the entire surface?
right.
That's what the question means. Now, that was Dr. Chetan. Yes, Dr. Chetan. See, when I use an etchant, even in a regular day, I use the etchant only on the enamel periphery. We rarely go and etch the dentine surface. We used to etch it for about 10 seconds when we had the 5th or the 6th generation dentine bond. Today, the current 8th generation dentine bond, which has the better monomers incorporated, like the MDP, the Meta, the Penta, it has made it highly bondable. It has got the hydrophilic and the hydrophobic ends both. So the bonding to dentine is much, much more predictable. And as far as the etching goes, to open up the dental tubules, we always clean the tooth first with chlorhexidine, and we now rely more on the interaction of the molecules of the bond to the molecules or the hapatite of the dentine. Because, and the two cases that I showed you were almost on the pulp. So if I etch, and if by chance the molecules, the monomers of the etchant, the liquid seeps through the dental tubules into the pulp, we may have an acid sting. Right? There's a term called the phosphoric acid sting. The patient immediately hits up with sensitivity. We don't want any sensitivity to set in, and we just want that we should not disturb the pulpal complex in terms of any stress that we give it. So in such cases, especially with the ones that I showed with Activa, I'm only using the 8th generation, which is a much, much more predictable bonding agent.
Okay, next question to Dr. Rohit. Dr. Rohit, how do you do occlusal adjustment post bonding?
On the articulator or intraorally?
Intraorally.
Obviously, using our articulating paper is the conventional use of articulating paper, where first we obviously check in the centric, and then we ask them to do minor protrusive and lateral movements. We eliminate the interferences, and always when we are eliminating the interferences, we should not flatten the cuspide. Rather, we should prepare along the cuspal inclines so that the morphology is maintained of the OVD. And obviously, we need a lot of patience and carry out these occlusal corrections. And once done, we polish the restorations.
Right. Dr. Rohit, as it is said, another question, as it is said that like composites stain over time. After some time, they stain. So since we are using composites below those veneers, does staining takes place there also?
The entire OVD or the prefabricated veneer, there's no question of staining because they have been laser sintered. So that's what when it's basically glass. The resin has been extracted, and hence even after we trim the surfaces, they have that great polishability. What we need to be careful about is the interface, that is the margins. So that once we should basically ensure that there is that's why for the prefabricated veneers, I suggested that we should make the proximal surfaces as well as the cervical area into a knife edge, so that there's a good merger between the restoration as well as the prepared tooth surface. And once it's bonded in place, we should be extremely meticulous in polishing the margins, because that's once it's well polished, the chances of it taking up stains is negligible. The underlying composite again wouldn't stain. It's basically the margins that we need to be careful about.
Can I add on something if I'm allowed to?
Sure.
If you said like this, I thought you were saying no.
Sure.
Okay, just adding to what Dr. Rohit just very nicely explained. See, the concept of Edelweiss or any indirect veneer, or even when we're talking about ceramic veneers using resin cements aside, is we laminate the inner surface. It's like your certificate that you get. You laminate it with a clear plastic.
Right.
Whatever stain comes, it comes on the top. The inner surface will never get contaminated. More so, a bigger problem with regular composite, direct composite, is the oxygen inhibiting layer.
Right.
So when the topmost layer is covered by the veneer or the occlusion VD, there is no chance of oxygen inhibiting layer. Oxygen is completely inhibited. So the inner surface is much more stable than a direct composite placement. And yes, the margins are the most critical. So polish them nicely, and once polished, use a surface sealant if you're not sure. Seal the margins with the sealant. And
Okay.
keep on probably checking with a thin tine of a probe if you have a gap.
Okay. Okay. Another question. And any training offered by Edelweiss in India? Whom to contact? I think they can contact any of you. Please
You
go
just-
ahead, sir.
You just type Advice Dentistry India, you will know whom to contact. Sadly, due to the pandemic, we are not doing any training. We have been extensively training in the last 3 years, but we are waiting for things to get better. But yes, if whoever wishes to discuss one-on-one, I am sitting in Noida. Dr. Rohit Shetty is sitting in Bangalore. If you can go to Dubai, Dr. Deepak Mehta right now is placed there. Please come and we'll be more than happy to give you a hands-on on that on a personal note. But courses, yes, let the pandemic situation get better, and we will plan that.
I think this is a concept that everybody would like to, like why we need that inventory. Also, I think on that point, I would like to ask you. We spoke about not giving crowns and giving composite. I will not say not giving crowns, but if possible, not giving crowns and giving good composite restorations. That brings me to if maybe there are many clinicians who are just starting and they might not have that much armamentarium, those many things. So what is your suggestion to them? Like uh, keep increasing them, like where to start if they want to go this way?
Okay, so now let me give you stages of armamentarium.
No, sir.
Now you've tackled the
No,
wrong bone.
I just wanted to ask, like, if I am asking you, I want to practice, conservative dentistry and endo, but I'm not sure if the material that I'm using, what should I do? Like, should I invest in one syringe and just do restorations with that? What to do, basically?
So your question is, I'm trying to open a restaurant. Should I only buy one spice and then as and when customers come, I buy more spices? See, I'll tell you what. The best part about restorative dentistry is that the armamentarium is not very extensive. It's a myth.
Okay.
Every practitioner that starts a practice has to buy a bonding agent, has to buy an etchant. Now, what we have added, you were saying, can I buy one syringe? I say, no, don't buy one. Buy one syringe of an enamel or a universal composite and just buy another compule of a dentine composite. Now, when you talk about crowns, you ask me, should I buy a rubber base impression? Should I buy alginate? Should I buy a retraction cord? Should I buy bite wax? And should I buy probably the trays to send everything outside? I say, don't buy anything of that. As a beginner, just buy a fiber strip, which is as small as probably half of this pointer, and keep that into the fridge. It will hide anywhere. The post is in a smaller vial. So the space also acquired will be much lesser when you start doing adhesive bonded dentistry. And my request to beginners is, practice it. Again, we're not saying don't do crowns. Though I have a huge program that I conduct, which is called the no crown concept. But if you like doing crowns, do it. But give this also a shot. And if in a few years you feel it's working, go ahead. See, because whatever you do directly, the number of vectors reduce, the number of hands it changes reduce. And as many hands, as many mistakes.
Okay. Now getting to a C, I think I just beh gayi, sir. I'm really sorry about that. But another question, Dr. Rohit, any special precautions that needs to be taken for the patient, like after giving them veneers? Any special precautions that patients need to be taken? Patients need to take.
For these prefabricated anterior veneers, very similar to the instructions that we provide to our patients who we've given them ceramic veneers. Like they should avoid shearing forces. but they work pretty well under compression. And again, probably a periodic checkup, so that if any round of polishing is required, we can always provide it to them. But to be honest, the instructions are very similar to what we would provide them when we would provide them ceramic veneers. I mean, like I said, the posterior OVDs work wonderfully well. They have good strength and hardness, what we expect from a posterior restoration. So once we've eliminated all the interferences and we've developed a optimal occlusion, there's no question of it fracturing or having any such issues. So they, under compression, they have good fatigue resistance as well. For the anterior veneers, yes, then shearing forces should be avoided, and probably a periodic follow-up with the dentist.
Okay. Are individual veneers available in market? Like if you showed about that whole kit was there. What if we use?
That's an advanced kit. Individual single veneers, single OVDs in differences are also available.
Okay. Okay. I think that brings me to the end of the session. Thank you so much to both of you for especially that question that I asked and you gave answer to that. Thank you so much. Thank you, sir. Thanks to both of you for sharing this concept. And I guess just like me, a lot of people will be there in audience who would, go this way. I will say at least explore this way. Think of exploring this way. So thank you so much.
Thank you, Dr. Pallavi. Thank you so much.
And last question, can we expect that future will be crownless dentistry?
Absolutely. My future is the present. I am not doing crowns.
Dr. Rohit,
As many people I can spoil, I'm spoiling them not to do crowns.
what about you, Dr. Rohit?
As far as crowns are an integral part of my practice. I can't lie about that. But again, it's a balance. When say it's a very conservative, the endodontic treatment has been done with a class 1 approach, I would go in with an OVD to rehabilitate that particular tooth. But again, if it's an extensive access opening, then I would probably place a post, then retain a core, and then probably give a crown. I would prefer a crown over an OVD. So it depends on the clinical situation.
Yes.
See, the crowns, and if I can extend that discussion to crowns to indirect restorations, the only place where even I would today do, I'm not saying I don't do it at all. In a year, I would still be doing 8 to 10 crowns around this. The only places where the contacts are more than 2 to 2.5 millimeters in width, if a 5 and a 6 and there's a long gap, I cannot close it with the composite because the unsupported material will fracture. So when you say crownless dentistry, that may be possible, but indirect dentistry cannot be replaced. Because whenever there is an extension, we will have to have either an onlay or an inlay-onlay combination, which can close the proximal gap or which can recreate the contour. And if direct dentistry is an artist's work, to develop that kind of hand, you cannot say, I will not do crowns for 5 years. If you are learning that, please do crowns.
Right. So outstanding question and answer discussion. Thank you so much, Dr. Rohit Shetty and Dr. Nikhil Bahuguna. That's from the viewers and the students who are listening. Thank you. Thanks to both of you. And thank you so much. That's all. Have a nice day. Thank you, sir.
You too. Okay, take care.
Thank you. So that was Dr. Rohit Shetty, Dr. Nikhil Bahuguna, and I took full benefit of this question and answer session. I am so happy that they were here to share whatever they have been doing and inspiring each and every one of us. So Henry Ford said that anyone who stops learning is old, whether at 20 or 80, and anyone who keeps learning stays young. The greatest thing in life is to keep your mind young. And these two speakers and clinicians have proved that if you want to stay young, keep learning, keep questioning, and keep exploring, I must say. As I asked that question, the reason of that was there might be many people who are just beginning with their practice or something, but it's very important to know where you are headed towards. As Dr. Nikhil rightly said, it's not that you can just remove crowns from your practice or anything like that. It's a gradual learning curve or a gradual practice curve, and we should follow that. On that note, I think today's session is done. We are done with today's session, and just one session is left, and that is on Saturday. So I am going to miss already, these discussions and these question and answer sessions especially. So on Saturday, we have Saturday, as I said, for just a pointer for those people who have joined us or who are seeing us now and have not registered for this conference, kindly do so. You have to download Eventi app, register yourself for DRDC event by clicking on DRDC and you will be registered. Do go there and fill the feedback form so that you can avail your certificate of participation and almost 40 CD points. There is one session left that will be on Saturday. We are going to discuss dental implants. We are going to discuss digital marketing. We are going to discuss impression and implants. We are going to discuss lasers. So mixture of everything is coming on Saturday your way. There will be two sessions as we always have on weekends. Two sessions, one in the morning and one in the evening. So we'll have two speakers in the morning, two speakers in the evening. So pretty excited for the last session. And yes, I'm going to see you there. Please, for those who are participating actively in this question and answer session and also seeing us, please do this. You can win Novolace dental therapy, laser therapy machine. What you need to do is, as I said, you need to register yourself for DRDCA app. Also follow us on FB DRDCA page. Take the screenshots when you're asking questions, when you're taking part. Tag your friends. There's one session left, so you can still do it. Keep doing that and send us the screenshots at drdca2020@gmail.com and you might be the lucky winner. So on that note, I'll end today's session and I will say a few lines. कि हम जा रहे हैं जल्दी आएंगे, हम जा रहे हैं जल्दी आएंगे, नहीं आएंगे तो कहाँ जाएंगे. I will see you for the last session that is on Saturday at 11 a.m. sharp. See you guys. Bye-bye. Take care.
Audio Jungle.
It's the fire.